likely to be successful. So that's why we need to use this One Health approach. And One Health approach, we need to collaborate with the people from other disciplines, and we need to learn to work with other disciplines. That's now how our systems are set up. You would see, human health ministries and animal health and environmental health ministries are sort of set up separately. And in almost all countries, that's how they work. And it's very difficult to sort of work with others, because they have their own budget, they have their own aims and goals, and their own problems they want to solve. But the issue is that unless we work together, unless we collaborate, it's unlikely that we will be able to tackle them. So coming to how tackling of emerging infectious diseases, can I ask about the time? Is that going okay? Yeah, thank you. Thank you. So now we learned about what emerging infectious diseases are, and then we learned about what is actually driving them. Now let's go to understand how we can tackle them. And to tackle them, there are lots of frameworks that have been prepared globally as well as regionally. And I've copied their screenshots there, and you should go and sort of download and learn what they are trying to say. But if you put them all together, they sort of boil down to those three things. So you want to prevent them from occurring, of course. And then if you can't prevent them, then you want to detect them early. And once you have detected them, you want to respond effectively. So prevention, early detection, and rapid response are the sort of hallmarks of all these guidelines and frameworks available globally as well as regionally. So they have, of course, multiple other components within them. But if you want to simplify it and summarize, you can say these are the three key features in how we can tackle them. And all of that also sort of leads to disease preparedness, where I will talk about that in a minute. So how can we prevent them? So prevention is very closely linked to the drivers. So we understood that these are the drivers for emerging infectious diseases. So prevention is basically acting on the drivers. So uh, one of these things is that this is a UN report prepared by the United Nations Environmental Program. And it's a good read. I would recommend you to go and take a copy, download a copy. So it's basically talking about the same things that we discussed. So if the diseases are caused by habitat destruction, then habitat conservation and restoration is the solution. And if it is caused by land degradation, then you should reverse that land degradation, promote ecosystem health, end wildlife trade and consumption, regulation of wet markets, monitoring of food systems, farm sustainably. But as you can see that all of these are quite challenging issues. You want to do that, but they are not something that you can do tomorrow. These are long-term things, and it requires a lot of effort and willingness of everyone globally to handle them. In addition to that, there are some things that we can certainly do is biosecurity in animal production, for example. We can enhance that. We can reduce the wildlife in livestock interface and improve land use. We can certainly vaccinate animals like Hendra, for example, in Australia, vaccination of Hendra in horses, and rabies, for example, you can vaccinate dogs. Vector control is actually happening in Yogja. It's a really good example from Yogja. And we don't didn't talk about the antimicrobials. That's another issue which is also sort of linking human, animal, and environment, and that you could do antimicrobial stewardship. So prevention is certainly possible and is far cheaper than response. But it's most of it is not in the human health domain. It is most of it live in the animal and environmental sector domains. So but some of these things that are required for prevention, like these ones, these are quite challenging to implement. But as long as you understand that that's how you would prevent them. If you tackle these drivers, that's how you would prevent them. But what we can really do is early detection and rapid response. So detect them early on if they emerge, and then respond effectively. Right. So now how can we detect them early? And we learned that majority of the emerging infectious diseases have an animal origin. So if that is true, then what is the best way to detect them early? How can we detect them early? So the best way to detect emerging infectious diseases is at the animal source or at the animal-human interfaces at this level when they are in the wildlife spilling over to domestic animals, not here when they are already in the human population. So if you want to detect them early, you will have to detect them in the wildlife or in the domestic animals. So to be able to do that, you need a trained workforce. Not only you need veterinarians who are trained in detecting disease early, you need environmental people, wildlife people who are trained in detecting disease early. You need good surveillance systems in animal and environmental systems. So the detection, if you want to detect early, then it has to happen at this interface, not at the human interface. So you want to detect the diseases here at this stage to protect the general population. So diseases emerging at the wildlife animal interface to protect the general population. And you are actually leaders in one of these things to why you have your eye sickness system, which is actually quite novel and world leading, I would say, and particularly in developing country. I haven't seen that kind of well set up systems established and run. So you should be proud of that. You already have this sort of surveillance system that is connected from field veterinarians, para-veterinarians up to the central level, and it is sending data, and you're collecting a lot of data. Of course, there are issues with it, like it's not as good as it can be. There is a lot of issue with how the data can be analyzed or better information can be gained. But Indonesia is certainly a leader in this space. The other thing to think about in surveillance is collaborative surveillance, because the real power of surveillance comes from joining it up. So humans are conducting their own surveillance, animal veterinarians are conducting their own surveillance. If they are not connected, it will be very difficult for us to detect diseases early. Die-off in wildlife, abortions in livestock, cluster of fevers in a clinic can be just one outbreak, can be just one emerging event. But if they are all being tackled differently by different ministries, while in the data is in different surveillance systems which are not talking to each other, then it will be very late by the time we will know about them. So there is a lot of talk about collaborative surveillance in WHO and FAO and WOA at the moment to try to make sure that these systems talk to each other and to actually establish systems that have data from both animals and humans, but it is not easy to do. It's because animal data is very different from human data. So we talking about farm level data, and the human is usually individual animal data, and there are a lot of issues about privacy and sectors. So it's quite a complex issue to implement, but this is the goal. That's where they want the global leaders want us to go to have a collaborative surveillance system. So, well, then the detection, then the next step is to respond to it. And to respond to it, we need to sort of understand how to investigate outbreaks, how to, and for that, you need to train your workforce to conduct outbreak investigations. Again, that sort of leads us to the same theme that all there are three domains. There is a one system, you have to deal with them all together. And preparedness is another term that is used. And preparedness is the your readiness of your country, for example, to deal with emerging infectious diseases. So these are the capacities that you develop, the systems that you develop, the plans you develop, and the people that you train to tackle these emerging infectious diseases. So that something emerges, then you are already ready to deal with it. It's like developing a fire brigade during the peacetime. You don't develop a fire brigade when there is fire is already on, right? So you develop a fire brigade before the fire is on in the peacetime. So this is preparedness is like doing that. So it is like developing your surveillance and laboratory capacity. There is these are the your eyes of the system and the diagnostics, the trained workforce, which are your people, and this is the most important layer here. And the plans and protocols and simulation exercises, sort of knowing who will do what and drilling it so that when there is an event, then you can actually tackle that. Having stockpiles and supply chains and logistics of vaccines, PPEs, diagnostics, cold chains, all of that. Financing so that you know which funds to use, contingency funds that you can release fast. Your governance and coordination, the emergency operation center, a clear command of chain, so you know who will lead the coordination of the event. Risk communication and community engagement is really important. That the trust you need to develop the trust before you need it. So preparedness is all of that that is built before the outbreak. But most important thing in this is I trained workforce, a workforce that is trained to conduct surveillance, a workforce that is trained to conduct laboratory examinations. That's the centerpiece of it. And that's what we are going to discuss briefly now. So what we are doing for workforce development, and UGM is at the centerpiece of that. So Asia Pacific Consortium of Veterinary Epidemiology is we established that in 2020 to build exactly that, to build the workforce capacity for preparedness, to build the capacity of the animal health workforce in the region for the early detection and rapid response to infectious disease outbreaks. So we are in our second phase now. So it is a consortium that involves all vet schools of Australia and New Zealand, and representatives from 8 countries in the region. So, and UGM was a member, a founding member of EPCO, and it is also still a member, and it's a key member that has contributed significantly to all the activities that we have conducted. We have an advisory committee represented by international organizations, and we are funded by the Indo-Pacific Center for Health Security. In the first phase, we have developed a training package of 36 e-learning modules and case studies across these 6 competencies on outbreak investigation, surveillance, risk assessment, One Health, biosecurity. It was a huge undertaking. So these are all the authors and co-authors involved in developing them. You would be able to see some of the people from UGM here. And we launched that in 23 at the World Health Summit, and now it is the most comprehensive open access training package of field veterinary epidemiology globally, and available in 6 languages, including Bahasa. So using this training package, in the last project, we trained 93 trainees from 7 countries, 7 countries. And in this, then we have a second phase now. In this phase, we are training 80 people, including 20 from Indonesia in this phase. The training is in 3 phases. We have an online training using these online learning modules, and then followed by hands-on field projects that they conduct in their country on outbreak investigation, on surveillance, on risk assessment. And then we have workshops on study design and manuscript writing linked with them. This is the Indonesian team. I'm grateful to them for being involved from the outset and contributing significantly to the EPCO activities. All right, so the take-home message is 4. I would say that emergence is occurring at the human-animal environment interfaces. We have seen several examples of this and how these are occurring, and emergence will continue to accelerate because the drivers are still there. We are not tackling the drivers. So all the drivers that we discussed are there. So as long as the drivers are there, the emergence is going to continue. So what we can do is to prevent, detect, and respond. We discussed that. We know how to tackle it. All the global and regional frameworks sort of agree on that framework. But the gap is the preparedness. And we need to be prepared to tackle that and to prepare them. As I talked about several things, but people are the central theme here. So you need to prepare your people to be able to work in labs, work on plans and financing, and a workforce that can investigate outbreaks, that can conduct surveillance, analyze data, conduct risk assessments. That is required. So the message is that emergence is inevitable. These are going to continue to emerge, but we need to be prepared for it. So I'm asking you to be the One Health workforce that the country needs, that the region needs. Thank you.
Navneet? Yeah. All right. So we have around 30 minutes for Q&A, and I think that's a very excellent and insightful presentation on how infectious disease continue to emerge because of interaction between human environment and also the animals. So if the audience here have any question, you could just raise your hand and state your name and where you come from and give this question to directly Dr. Navneet. Yeah.
Okay. Good morning, everyone. My name is Muhammad Aksen Soldra. I'm from Indonesia, especially Southeast Sulawesi. And now I'm a medical laboratory technology. Professor, you mentioned that preference depends on people. In your opinion, how can medical laboratory technology move beyond diagnostic testing and become active contributor to surveillance and outbreak prepared within the One Health framework? I think.
Yeah, thank you very much. Yes, I talked mainly about epidemiology, but that's only one piece of the puzzle. So laboratory technicians and laboratory scientists have a great deal to contribute in diagnosing emerging infectious diseases. And you have a great role to play. I guess what is required is that training laboratory technicians and scientists in diagnosing these diseases early on, and also collaborating with animal laboratory technicians and animal scientists, laboratory scientists, to understand their perspective and understand how diseases are happening in animal populations. I think that One Health approach is so important, and thank you for joining that. And then you are already on the right path where you are joining this One Health UGM course, and that's quite helpful because now you are working with learning together with veterinarians and people from other sectors, and this will develop connections, that will develop partnerships that will go beyond this workshop. So that will help you collaborate with the other sectors. So understanding the problems of the other sectors is important, and that you will get here. But then collaborating with everyone is so important, and this is the first step that you have taken. Thank you.
Okay, thank you. So anyone else from this audience? I think from the corner over there.
Hi everyone. Hi, Navneet. I'm Duala. I'm from Yogyakarta. So since emerging infectious disease is a complex, wicked problem involving not only human, animal, and environmental sector, but also the culture, the economical, and the psychological aspect of people. So I wonder to what extent One Health should involve social scientists such as anthropolog or sociolog or maybe communication experts, not only in the risk communication and engagement level or the governance and coordination, but maybe much more earlier, maybe from the beginning. What would you say if maybe we could involve the social scientists to complement the expertise of microbiology or medical scientists to map out since the beginning to identify from the contextual, the cultural, economical, social, so to identify why such disease emerge and location.
Exactly. And you have said it better than I can say. So yes, these are so important, social scientists and all these people with communication and social scientists are very important. I actually learned this early on when I had an equine influenza project. We had an equine influenza outbreak in Australia, and we developed an epidemiology project in how the disease outbreak is spreading, what is causing the outbreak. So understanding how the virus is spreading from one horse property to the all sort of technical side of things. But ultimately, who implements the any control program, any biosecurity thing, then any program you develop, the implementation is by humans, not by machines, right? So we realize that we need to better understand what horse owners think. Obviously, we can develop a good control program based on disease epidemiology, but we need to also understand what works and what doesn't work. So if the horse owners are not implementing, for example, biosecurity, then whatever design you develop is not going to work. So I had then two PhD students, one working on the epidemiology side of things, and the other person actually working on understanding the horse owner behavior and the psychology, and that was so important. And since then, I have involved a psychologist and collaborated with them in almost every project that I have implemented. We had actually a project on Hendra virus, specifically focusing on horse owners, and a longitudinal study on horse owners for 4 years to understand why, what are their perceptions, and what are their so vaccination, for example, in horses was a major issue. And one of the things we found that the horse owners, they're not vaccinating against Hendra because they think that vaccine can reduce their performance. So we then actually conducted a study to understand whether there is a reduction in performance due to Hendra virus vaccine. And we objectively confirmed that there is absolutely no effect of Hendra vaccine on performance. So, it is a collaboration between these two sectors, and multiple sectors is so important. So when I'm saying human, animal, and environment, these are just the sort of the centerpieces, but then the professionals are required, are a variety of professionals are required, and social science is very important in all of that.
Does that answer your question, Dwala? Okay, thank you. Now, I think we have questions from the online participant. So this is the question.
Yeah, that's a really good question, and it's a really good example of One Health, an interface between animal, human, and environment. So antimicrobial problems are not just human health problems. So there is widespread sort of use of if we want to tackle antimicrobial problems, we'll need to tackle them at all three levels, right? So we will have to work with our veterinarians, work with our farmers to educate them about the use of antimicrobials, the effects of these antimicrobials, also to reduce the um, you use of antibiotics in humans. So, for example, then there is so much environment. The fish is basically living in water. So it is a really a good example of how animal and environment and human health are interlinked, and how we can tackle them. And then there is a lot of work being done in antimicrobial stewardship in many of the countries. And the latest data from VOA is actually indicating that the use is coming down. So this is one of those problems where it's a bad problem, but it is inspiring to know that things are reverting. We are changing things based on the work that we are doing. So there is a lot of work needs to be done. Of course, I'm not an AMR expert, and you will have a lot of other people sitting there. But what is required is that collaboration that I mentioned between human health, environmental health, and animal health people. And because all these problems are multi-sectorial, these are not problems of a single sector. And also social scientists, why farmers are using antibiotics, why people are taking antibiotics, why they are available, for example, to use. A lot of social and psychological issues need to be investigated. So it is a good case study that where actually One Health can be applied directly.
Hello, sir. Thank you so much, Dr. Navneet Dhan, for your insightful presentation. And thanks to UGM and all organizers for this wonderful opportunity. Thanks all. It's truly honor for me to be part of this course. My question is, I live in a rural village, in rural or village communities. How can local people be practically involved in simple and affordable ways, effective ways to support disease surveillance and early outbreak detection? This is my question. Thank you so much.
Thank you. That's a really good question. And I actually grew up in a village in India. And I can tell you, you are from Pakistan. I can see that we have a
Yes,
very
I'm
similar
from
culture.
Pakistan.
Yeah.
Yes.
So village people actually live with animals, right? They are not
Yes, yes.
where animals are not living in farms. And I can, we had animals living in our. If you go to any house, you would have people and animals living together. So people in
Yes.
India, in villages, would come to know about any problem firsthand. And we were developing a project where we would actually communicate. We were training women in villages because they are the most. They are the people who actually handle animals most. To train them to provide first-hand information about disease in humans and animals. So, for example, if their child is sick, but also their animal is sick, they would be the first to know. And we developed actually project to um, train them. Unfortunately, that didn't it was funded, but then it was withdrawn. But that is the way to. So I think the people in rural areas already practice One Health. They are already have a close connections. It is more to capture that information from them.
Yes.
It's more to engage them in this early detection and surveillance.
Yes.
Thank you.
Thank you so much, Professor. Thanks so much for your detailed answer. Thank you so much for your time.
Thank you.
Okay, thank you, Sundas. Anyone else from the Zoom? One more. Oh, it's from the question. So, Dr. Nafit, can you read this question, or should I read it back to you?
Yeah, I've answered that. The second one, yes. All right. Given the global need for animal protein, the risk of the new disease emergence from that's a really good one, and that's why I said it's not easy to tackle those drivers of emerging infectious diseases, because we also need food security, we also need protein. But what we can do is we can have a system where we have a good biosecurity. We have certain guidelines for how farms are managed, how farm animals are kept. And biosecurity would mean that the diseases are if the disease emerges at a farm, then it can be contained in that farm or in that village. And biosecurity would also mean that it's less likely to then transmit it to other villages and other countries. But also, if you have biosecurity, it's much more less likely to be transmitted to humans, because you have you are using proper hand washing techniques. You are using not allowing visitors to come in contact with farmer. You're using PPE to when you're handling animals. So biosecurity is one of the answers to those problems. We still need protein, right? We still need food security, but we know that the intensive farming are causing problems. So from intensive farming, we need to sort of move towards sustainable farming, and proper biosecurity procedures, while still ensuring that we have enough food to feed our people.
Okay, Dr. Nafid, can you give the question, the previous question? One more question. Okay, so there's another question from Daifullah Abian, Indonesia. Dr. Nafid, can you explain given that Indonesia is one of the most largest fishery producer, how can antibiotics used in aquaculture sector trigger antimicrobial resistance or AMR, which impacts public health? What are the public strategies and measures to address antibiotic dependence in this sector?
Yeah, a great question. And the antibiotic use in aquaculture is a problem because that is actually, as I say, it is causing antimicrobial resistance, which is impacting human health. And these, I would say, these give the same answer. So if you have good biosecurity, you would need less. You would need less use of antibiotics. If you can use those biosecurity approaches that are specifically designed for aquaculture, you would have less disease and less use of antibiotics. But also there are obviously guidelines and frameworks available to tackle antimicrobial resistance. And I can put you in touch with my colleague who is actually has a project in Vietnam and in probably also Indonesia, and dealing with antimicrobial resistance in aquaculture. It's a big issue, but it is tackleable once you have to deal with all these biosecurity issues in aquaculture.
Okay, thank you. So I think we still have around 10 minutes for the Q&A. Anyone from the audience would like to give a question? Sorry, there's 1, 2, 3.
Hello, good morning, everyone. Good morning, Professor. So regarding the Nipah viruses, as you mentioned before, I have two questions regarding the pathway of transmission. So as I understood, as you mentioned before, the pathway is from wildlife animals into the domestic ones and then to the humans. So especially for Nipah viruses, from the fruit bats and then to the pigs and then to the humans. So I'm wondering, so is there any domestic animals that we need to be taken care of rather than pigs? Or is there any domestic animals like which can be infected rather than pigs from the bats? And then my second, you would like to answer the first?
Yeah, go on, ask. Yeah.
So my second question is like for the transmission for the pathway, without involving the pigs, the intermediate, like the source, the host, like can it be directly transmissioned from the bats, the natural host, to the humans?
Yeah,
Thank you.
for the Hendra virus, it hasn't. We haven't found that in Australia that the virus is transmitted directly from flying foxes to humans. So they're transmitted via horses. But Nipah virus is something that for in the recent outbreaks where there was a connection with the use of with a direct connection with wildlife or coconut trees, and when people are collecting that sap, there was a connection of with direct connection with the bats and wildlife. I'm not sure of any other intermediate host, but there is for Nipah virus has been shown that there is a sort of direct connection. But in Hendra virus, it hasn't been confirmed directly from flying foxes to humans.
Dr. Navin, I understand you have a meeting at 10, so is it possible for one more question? Or should we end this one?
Yeah.
Okay, so one more question, just one, sorry.
Good morning. My name is Mazaya, and I'm from Jakarta. Thank you, Dr. Navneet, for the explanation. So, my question is a bit related to the previous question. So, we usually know the disease is when it reach the domestic animal. For tackling EID, like what you said before, we should detect early in wildlife to domestic animals, right? Like usually what I see, like we know the disease is when it reach the domestic animals, like some are dead, like in the poultry or our livestock. And I'm wondering, like, do we need to detect before that? So we need to detect like in the wild animals. So before we do quarantine or vaccine to the livestock, so we can detect the disease like even before that, or that's the earliest
Yeah.
thing that we could do, like in this current
That's a
situation. Yeah.
really good question. If we can, so there are two angles to it. Can you detect them early in wildlife? Yes, you can detect in early in wildlife if wildlife is monitored, and there are rangers, for example, who can tell you about some deaths in. So, for example, deaths in pigs or deaths in wild birds, that could probably indicate something going on with the. And then people have seen in Vietnam, for example, when there are deaths in a forest area, and then there are the diseases actually spread in the surrounding villages. But what you are saying that is also correct. It's much more easier to monitor our domestic animals because they are in our constant vigil, right? You are in contact with them. You can know that they are showing clinical signs, whereas wildlife is challenging. So yes, you have to do at both of them if you can, if you have a service system in forest areas to surveillance them, that's fantastic. But and that can also give you an early sign that something is going on, and they could prevent. Then you can act early and sort of if you can tackle that outbreak, for example, in the forest area, then it doesn't sort of spread over or spill over to surrounding villages and animals. But what you said is perfect. That in domestic animal we have a more chance of detecting them. That's why it is so important to train our veterinarians, train our para-veterinarians to be aware of the clinical signs and diagnosis of these diseases. And it's so important for our farmers to report these diseases, and is a central piece of the surveillance system. So yes, both.
Okay, thank you. Can you give another round of applause for Dr. Navneet for his presentation? Thank you, Doctor, for the excellent and valuable insight on this topic. So
Thank
I think
you.
you have to have another meeting. So thank you very much
Yes.
for participating from the Australia. See you next time
Thank you
on
so
the
much.
next on the next venue of One Health. Okay, so I will give another small information. Maybe we have a short coffee break for around 15 minutes. So I hope everyone will have a coffee breaks beside this room. But I'm sorry we cannot bring this coffee and snack into the room. So we'll be starting the next session on Professor Dr. Sri Wibowo at 10:15. Okay, thank you very much.
Sorry, I
Yes,
just
Nafit.
shared a link to it just shared a link in the chat to a NIPA article I had written during the sort of recent outbreak in India. So just sharing that link in the chat.
Okay, so see you next time, Nafit, and thank you very much for your participation. Okay, so we can go to coffee break.
Check, check.
Ya, sampai jam 11.
Iya. Aku telat ya. Kalau Senin pagi.
So it's already 10:15. Anyone who is still outside, can you please enter the room? Because Prof. Tri Wibawa will start the lecture. And yep, we will start soon. So once again, can anyone outside this room enter the room so we can start the lecture? Okay. Right. So how's the coffee break? I hope it was enjoyable. We will start this lecture on the second lecture. It will be brought by Professor Dr. Trevi Bawa, PhD as PMK consultant. He's my senior colleague. We know each other for quite some times, and he is a specialist in fungal. And of course, he's a professor at Department of Microbiology, a head of task force at University of Gadjah Mada on One Health, and he's the chair of the Research Ethics Committee, Faculty of Medicine, Public Health, and Nursing, University of Gadjah Mada. And what he will bring today is on the One Health in Indonesia, barriers and way forward. So I think the important because it is important because there's challenges we are facing in infectious disease, and also the climate change and how intersector coordination is needed for this in response to the climate change and the increase of emerging disease. So I think we have Professor Dr. Pawat here, and the floor is yours. You have 40 minutes until 11 o'clock. Yeah.
Thank you, Dr. Edwin. Good morning again. So this this is my topic, One Health in Indonesia. I hope it is not it is just a case study because it might be applicable also in another part, maybe in Pakistan or other Myanmar or other countries that is have a almost similar situation with us. Please, next. Yeah. So again, I will introduce about One Health. Yeah. To whom not yet really familiar maybe, but I'm sure that everybody familiar. But to make sure that we have the same page, the One Health is not like other term for insurance. We have health insurance that called as One Health. We have a system that is managed by our Minister of Health. The same terminology, One Health. But we're talking about One Health that is approach. This is approach where there is a collaborative, multi-sectoral and transdisciplinary approach working at, it can be local, regional, or global. And then the aim is to integrate between the human health, animal health, and environment health within one scope. So basically, we don't have the pointer. Yeah. Basically, we we will integrate these three sectors. Thank you, Pak Edwin. These three sectors, and we need to do collaboration, we need to do communication, and we need to do coordination. Hopefully, if we have communication, coordination, and collaboration, so the three sectors that is usually have a different aim, different task, different job, different degree, and different KPI, for example, then they will work together to make sure that these three sectors, the health of animal, health of human, and also environment will be will be one entity that is going to be one package, right? Next. Okay, so I like to bring one example where One Health approach will be suitable and applicable in Indonesia and also in another country maybe. So the first is about zoonotic and emerging viruses or emerging disease. Previous lecture concentrate in emerging disease. So it is almost similar with this one. But here, why it is important in Indonesia is because there is a direct threat between us, right? Rabies, anthrax, and avian influenza is the, what do you call it? It is a classic example where we can apply the One Health approach there. And then another situation why the zoonotic and emerging viruses is important in Indonesia, because there is a high risk pathogen that is maybe it can be a pandemic situation or pre-pandemic situation because of the close relation between the human and also livestock and also wildlife. And the third is we have a lot of vector-borne disease, right? Why it is important? Because this vector-borne disease, somehow it is really what do you call it? It can be changed the situation because of the climate change. For example, for this dengue and malaria, it has vectors. The vectors is mosquito, and because of the climate change, global warming, so the habitat of these vectors is not only in the equator area. It can be transmitted to a little bit further to the subtropical even. So in that case, before maybe the countries or maybe the area where previously doesn't have the mosquito a lot, now becoming have mosquito. And then of course the dengue and malaria will be spread very easy because there is a vectors. Next. Yeah. So against why Indonesia? Because another factor is that we have a very huge biodiversity. We have a lot of tropical plant. We have a lot of wild animal, and we have also many insect, for example. So it is because of the reach of this biodiversity, it can be correlated with the possibility that viral pool also there, or bacterial pool, or other microbes or other germ that might be correlated or associated with the plant we have with the animal, wildlife, and also insect other, that is possibly one of the sylphatic circulation will be there, right? And then the proximity among human and domestic animal and wildlife, because of the human encroachment make people need housing, people need food, right? And we starting to build our housing in the middle of rice field, for example, or we using the wood to plant some rice or other food. So in that case, the deforestation and the change of the landscape will be not evitable, right? So in that case, the proximity between the people and the animal, and also the factors and also reservoir will be close enough to make sure there is a spillover among them, right? And then we have proof historically that we have avian influenza in 2006, for example. Rabies still now we have, because there are many dogs that is surrounding in the neighborhood, not in Jogja maybe, but in other places, for example in Bali or in other island that is they are culturally they are allowed to have a dog in their neighborhood or in their house, right? And then next, bisa nggak sih? Bisa nggak ini? Bisa ke sana apa ke sana? Ke sini. Okay. Okay. Yeah. So this is the numbers where we can start to understand why the emerging disease or new pathogen emerged is quite related with the wildlife, because we still now convinced that almost 45% of the emerging viruses, emerging microbes that is affect our our health, human health, will be from the wildlife spillover, and also 30% will be from the domestic animal and livestock, and only 25% directly from the air environment or human to human. So in that case, now it is really reasonable if we're thinking about the emerging disease or pandemic preparedness or whatever we can identify our problem, especially in the zoonotic disease, will be related with the animal and also environment. Yeah, so we're talking about the spillover, right? At least we can identify 4 or 5 factors why the spillover can be accelerated by this situation. The first is about habitat deforestation. Yeah, habitat disruption. For example, for the change of the landscape and change of the or maybe forestation, as I mentioned before. So in that case, the wildlife that is usually have a habitat in this wood, because we starting to open this land, then the proximity among human and this animal that might have the certain pathogen that is never been identified even, then it is going to be close interact. And then another possibility is that because we need a lot of food, then we starting to do agriculture intensification, right? Agriculture intensification in this picture is about the livestock, because livestock is like a genetically similar host, right? That will able to facilitate to the for the pathogen to mutate among them. And then because of the intensification, as I mentioned before, we starting to do the deforestation, because we need land to plant our rice, to plant our food, right? And then another possibility that is accelerate the spillover is because of the global transportation. For example, today we have spillover in this town, and then maybe tomorrow you will have this situation from human to human transmission in another place, maybe in Taiwan or maybe in United States or even further, that we cannot imagine because of the global transportation. And then the next is the contact zones. Now in Indonesia, we have still the wet market where people, what do you call it, selling the wildlife to be consumed. In that case, of course, the possibility that human interaction with the wildlife will be increased. And even because they're starting to slaughter, they're starting to consume, then of course the possibility of people get infected from directly from the blood or from the fluid that is excreted by this animal will be increasing. So in that case, the spillover cycle will be accelerated. Yeah. And the disease emergence here, the people becoming sick. It is possibly directly from the wildlife. As I mentioned before, we consume wildlife, we slaughter wildlife, and then of course the excrete and also the blood will be directly contaminate us. But another disease might have another pathway, not only directly from the wild ecosystem to the human, but it can be facilitated with the intermediary amplifier. For example, here with live animal markets, as I mentioned before, and then second is through the intensification of farming or for the livestock. Okay. Yeah. So this is this is one example that we have. This is that is related with the livestock. previous lecturer saying about the avian influenza, and it was true. In 2006, I cannot imagine if there was pandemic in that time, right? Like COVID, maybe we are not in good condition to be prepared for the pandemic situation. Yeah, the laboratory, the laboratory capability, and then the surveillance, and even the human resources was not really available in that time. Yeah, but lucky for us in that time, 2006, the avian influenza pandemic was not happened, right? Rabies now we have still, we have a Nipah race just before, but we never have it in Indonesia. COVID-19, there are million people die in Indonesia and also in other countries. Dengue expansion, dengue infection, we have a lot every year. It's like a annual cycle. We have the dengue. Malaria, we still have malaria, especially in the very east part of Indonesia. We have a lot of malaria cases. So that is why the zoonotic disease will be the first concern, especially that is need for us to apply the One Health, because it come from the animal, and the environment will be the buffer of the transmission among the animal to human. Okay, the second example will be the antimicrobial resistance. Is it pandemic? Yes, we call it as a silent pandemic, right? Because we have this situation that people got infected by the bacteria, fungus, or virus that is already untreatable by the antimicrobial that we have now, right? And then because of that, it can be affect many people. It can affect many people, not only the poor. It is also the richest. Not only the people that have low education, but even the high people that have high education, it is possibly got infected by this antimicrobial resistant situation, right? And then now globally we have around 1.2 or almost 1.3 million deaths attributable or associated with the antimicrobial resistant or because they get infected by the bacteria, virus, and also fungus that is already not able to be controlled by our drug, our antimicrobial substance. So why? Nah, the most important thing is because of the unregulated human misuse, right? That is in my field, of course, human use, and because I work in the hospital, so people understand that many doctors give the antibiotic that sometimes this is not necessary, right? But actually, we have also another situation in the agriculture, right? Though there I put one thing that antibiotic as a growth factors. We are banned already. Government does not allow. We have a regulation that the antibiotic cannot be used as a growth factors. But who knows, right? Yeah, because not like in human, we give the pills using the prescription, right? What about in the agriculture? Because they maybe put as a supplement for the food, for example, or even before there is a discussion about the aquatic culture for the fish. They just put it in the water, actually, right? So how can we control that one, right? And then the overuse of or misuse of this antimicrobe will give us situation, we call it as selection pressure. Selection pressure means that we are actually unintentionally or intentionally select the microbe that is resistant. Yeah, we kill the susceptible one, but the resistant will be remain. and this remaining unsusceptible microbe will be circulating among us. So the probability that we can get the microbes and we getting ill because of that is only associated with the what? With the resistant one, because the susceptible has already cleared out, right? Okay, next. Yeah, these are the figure that can be used to understand why the antimicrobial resistance is associated with a situation where it is in animal environment and also in hospital. This is three sectors involved, right? If we talking about the antimicrobial resistance, we have to consider about this antibiotic residues. So because we give the antibiotic to the animal or to the human, then the residue will be there, right? For example, I prescribe my patient with antibiotic in the hospital, and then the residue of this antibiotic will be in the wastewater, right? And then the second thing is the antibiotic resistant bacteria itself, because many bacteria that is already not susceptible to antibiotic in our hospital, and it is infected our patient, and it is also in the infrastructure, right? In the bed and in the whatever in the hospital, because they can just attach to the wall, for example, or in the floor, for example, and then it is possibly that they can be transmitted to the through the wastewater again to the environment. And the last thing is that antibiotic resistant gene. Why we need to consider this? Because this gene can be transmitted among bacteria, not only from the bacteria that is able to infect human, but it is possibly also transmitted to the to the to the microbe that is actually not human infectious. It is not sorry, it is not an infectious pathogen for the human, but they go to the wastewater, they go to the water body in our river, for example, then they're going to meet with a bacteria that might be in the environment, and they transmitted the gene, and then this bacteria becoming have the gene, and then after that the next when they meet yeah when they meet the bacteria another bacteria, they will transmit again, and after several transmission it can be come back to the human and also in the animal. In that case, of course, these three will be important. I mentioned about hospital. What about in the farm? What about in the aquaculture? The same situation, right? Because we use this antibiotic in hospital, the same thing we use in the farm. The same situation will be happen. Okay, we share the antibiotic resistant bacteria, we share the antibiotic resistant gene, and we have the antibiotic residue among us. Okay, so how can we tackle down this problem if only in the human sector will think, and the animal sector will have a what policy or intervention, right? It should be one health here. Okay. Yeah. The third threat is about the environmental amplifier. We call it as, for example, we have pollution, right? We have poor chemical. We have a chemical effluent that is come out from our household or from our industries or our other institution, right? And then go to the river and then go to the sea, right? And then untreated clinical wastewater, right? We understand that our hospital maybe have the wastewater plant actually, But for the quality assurance, they are not counting about the antibiotic resistant gene. They are not counting about the antibiotic residue, and they are not counting about the antimicrobial resistant agent, because we just check it the bio bio POD itu apa mas? POD itu apa POD? Yeah, but yeah, he's the expert, all right? Biological oxygen demand, right? That's our indicator in our wastewater plant, right? So actually we missed the 3, right? Also in the hospital, also in the farm and other institution. And then the next is about the this one. Because of this situation, can you imagine? It must be rodent and other factor will come, and then it is going to be exaggerate the process of the transmission of the zoonotic disease. Okay, and these are the plastic that we have. We still have plastic there, right? Here. So plastic is always problematic because you can see this. This is the curve where the industry making a plastic good, right? So it is like exponential curve, right? So we are using plastic a lot, actually, right? And then the problem is here, plastic degrade very slow and even cannot be degrade, right? Only 9% of this waste, plastic waste, is recycled. And then after that, you can see that almost 80% will be end up in the landfill. So now if the production is increasing and then 80% will be done in the landfill, then you can imagine how many plastic will be accumulated every month, every day, every minute maybe, right? But if you have this plastic, for example, you have this one, and then somebody just throws it out right there, you can just pick it up, right? And then put in the recycle bin. But the problem is if this becoming microplastic, right? Because it is going to be degraded, right? And then the microplastic is still there. So yeah, we're drinking the microplastic. We eating with the bonus of microplastic, of course, right? And these are the situation that we may have to consider, that microplastic and plastic will be correlated with this. Why it is climate change? Why? Because the industries that we use to develop plastic will contribute around 13% to 20% of the carbon dioxide emission. So it can be trigger for the climate change. The second is biodiversity loss. Because what? Because if you have plastic, you have microplastic outside there, then the possibility that there is plant, there is a insect, there is a wildlife that is going to be endangered because they got poisoned by the microplastic. The third is that disruption of absorption of carbon dioxide, of course, because of that, right? And then impact to our health. The human health have directly correlate with the microplastic. The animal health, right? So if you're talking about the animal is our food, are you agree? Yeah, you are agree, right? We are agree that the animal is our food, right? So if the amount of this what do you call it, the animal is decreasing, then of course we are going to starving because of that, right? If, for example, in our sea there are many fish and other animal that is habitat there becoming poisoned by this microplastic, the production of our fish will be decreasing. So how can we give how can we feed 9 billion people that is living in our earth? So that is another problem. Okay. So now we concentrate about the detection and response before before when we talking previous lecture talking about what? Talking about the prevention, detection, and response, right? So now we only concentrate between detection the problem because we have already, for example, and then waiting for the response. And these are the problem we have right now. Also Indonesia, maybe in another country, maybe in the same, right? Government and policy gaps. There are silo among us. The people that is working in human sectors are always very dumb to what? To talking with the people that is working in the animal sector. And even between this sector, they cannot talk each other because they actually from another planet. They talking with different language, right? I'm a human. I'm MD. Then I will talking just like I understand everything, right? With a very very specific terminology of medical thing. And then of course the people that is working in the environment cannot understand what I mean, right? And vice versa. I cannot understand what people that is deal with the environment and the animal because I am not really understand because I never learned about that. Okay, data fragmentation. Of course, we have surveillance in human being. We have surveillance in animal. Do we have way to combine that one? No, sometimes we don't have resource constraint. Yeah, people that is understand to make them the three speak with the same language is really very very rare, right? And another thing is that this resource mean money, financially. Maybe we don't have awareness and culture. Awareness about the One Health itself, the culture. Somebody just mentioning about the social science, right? Yeah. How can we understand? Right? How can we understand the anthrax situation if we don't know the social setting of this anthrax, the social setting of people having one cow or one sheep in the backyard? It is really true investment for them, right? How can we say, you get anthrax, please stamp out, just kill it? No, not like that, right? Because it is investment for them. Eh? It is their money, actually, right? And then implementation weakness, of course, that one. Yeah. So the high risk environment, as I mentioned before, at least we have 3 example, and then amplified by the fragmented data and siloed governance, meaning uncontrolled outbreaks. So now, where are we now, right? We have this problem. And if we have also the same thing, this problem, then it is going to be doubled or even triple or tenfold or even hundredfold after that. Uncontrolled outbreaks, right? Okay, so these are the paradigm shift the matrix. This is fragmented. Can be applied for the surveillance, governance, AMR management, and also response. And here is the unified. So you can just what do you call it? It's just dibandingkan. You can just compare it, right? You can compare. If it is unified, then the surveillance will be real time and integrated, and here it will be segmented, for example. Okay, and then actually, all of us, not in Indonesia only, another country maybe have the same asset. We have digital growth. We have digital technology because everybody now have a smartphone. Now people have starting with this one. These are what? AI, right? We're using AI. Even we are now, if we go from this campus to some restaurant, for example, we are not thinking anymore because we're using the AI again, right? Yeah. So we have digital, digital. What do you? This is a capital, right? And then we have academic strength like you, right? Like all of you, the academic strength. You have the power of your intelligence and also understanding about the One Health, right? And then we need to learn from the developed nation also that they have what do you call it? They are not they just starting earlier with us, so it is possible for us to just catch them, right? To catch them, and if we see the situation, I think we need to become the first because we have the problem there. We have zoonotic disease, we have AMR, we have the pollution, and what other problem that can be suitable for the One health. Okay, this is the situation. If we have surveillance, right? We have surveillance, right? Surveillance for the problem we have. There is a real-time data collection. Of course, we have. Every sector have that. We have sentinel surveillance in a very high risk area. For example, the Fed has been noticed that certain districts have anthrax, have certain districts have avian influenza, right? But the system is not integrated. Yeah, we need to cross-sector information sharing. In that case, we're going to have a good early warning system if we can combine that one, right? Yeah, this is the situation if we are still in a silo, and this is the situation if you have integrated surveillance metrics. The information flow, the systematic feasibility, and operational stance will be quite different. Everybody must understand and convince that the integrated will be better comparing with the sectoral silo, right? So this one, for example, the human sector, animal sector, environment sector, they're starting to collecting the data. The syndromic surveillance, for example, we have people that have a dengue virus infection, for example. And then here, maybe the animal sector starting to uh, 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 to to collect the livestock mortality rate and other thing. We have here anthrax, for example, and then also in the environment, they starting to collect that, and then they combining, and then maybe they will able to predict what will happen. Yeah, for example, in the human, right? In the human, the doctors starting to reporting some unidentified illness with a with a with a fever, for example, and then from the animal sectors, they saying starting to reporting that some animal also have a similar situation. The animal starting to die earlier, right? And then the environment sector is reporting that this area has deforestation. So in the interaction with the people that get sick because of have a fever might be correlate with the die animal, right? So I'm sure that if we have that system combined, then the early warning system will be work much more better comparing if it is not combined. Yeah. Maybe some of you in Indonesia have ever heard about it. SIZE is a System Informasi Zona System Emerging Infectious Disease. This is the system that is bring by the coordinator minister. So they are coordinating the three Minister of Health, Minister of Agriculture, and Minister of Environment. Previous lecturer just mentioned about this one, sickness that is in the animal sector, and these are the human sector, and these are in the forestry and environment. They reporting about the wildlife disease. So using this platform, this SIZE platform, they can combine the three, right? Yeah, it is. It was only 2023 start. I hope it is work, right? But I heard from Prof. Vishnu, he's expert wildlife. He's saying that these are very weak. The most point is here because not many people working in the wildlife. very only view PetMed working in there. So how can we expect it that there will be a report from the wildlife? Yeah. But still, the system is there. Now we can just push to use it, right? Okay, and then how do we move forward about it? So one thing we have to consider becoming two point, right? So first is how to leverage institutional capacity, and the second is to do the community integration. One of the student just asking about the role of the community, right? So here is, yeah, we need to change the behavior, like thinking in silo, thinking that the health of people is not related with the animal, for example. We have to change that. And then stakeholder involvement, right? So every sector have their own stakeholder in front in the field, right? Maybe if in medical, in human, they have if we call it as apa kader, yeah, people that is in the community that working in the human health, and maybe we can have the same thing in the animal health, right? And then here in the governance, we trying to allow to increase the capability of the workforce, like us, for example. We need to leverage our infrastructure, including digital platform, and also make sure the sustainability, not only 1 or 2 years program, but it's going to be continued until whatever, berkesinambungan itu apa bahasanya?
Continuous.
Continuous. Yeah, sorry, I have a struggle in bahasa Inggris. Yeah, and then this is the public awareness. We need to increase the awareness among our people about the wet market. It is related with the zoonotic disease, about self-medication belief. I think in another country also the same thing, right? Sometimes we go to the drugstore and asking for antibiotic, for example, and when these people was asked why you need antibiotic, because I have a headache, because I have a toothache, for example. Yeah. So we need to, thank you, we need to train them, right? Zoonotic disease, the same, right? Okay. So at least there are 4 steps that we can do, right? First, we need to align between the problem between among the 3, and then integrate the surveillance, integrate the capacity, integrate the approach, for example, and then increasing the capacity, and then make sure people understand, then make sure people will join how to align and integrate the force, right, in animal or in human, and also in environment. And I just want to share that we has just newly published a book. This is this many chapter inside this book, and then the writer is among us, the member of One Health Task Force in UGM, and also student, and also other practitioner. Okay, maybe you can just access that one. Thank you very much. Yeah.
Thank you, Prof. Tri. Could you still wait at the front? Now we have around 20 minutes for question and answer. 20, yeah, Prof. So anyone, first of all, in this room, yeah, over there. I'll go over there. State your name and where you come from.
Thank you, Prof. Tri, for the amazing material for us. My name is Rizna. I'm from International Health Program, WHO TDR, and I want to ask about, if we have a very limited resource, what do you think need to be two first, the institutional capacity building or the community capacity. Thank you.
Okay, that is a very intriguing question. Which one? The community or the government, that is including regulation, right? I think we cannot choose, right? We have to do both in parallel, because if we have and we have a regulation, for example, the implementation will involving the community. Like I just mentioned that we have regulation, very strict regulation about the use of antibiotic in the for the growth promoter, but still the problem is people starting to using that as a growth promoter. We have a program for we call it as antimicrobial stewardship in our hospital, in our clinic, but still the doctor is still using this antibiotic overuse, because they believe that they need to do that, otherwise the people die, for example. So we cannot choose. You have to working together in both sides. Yep, very limited resources, like tricky, right? Yeah, you can say that limited resource, but actually you have, for example, as I mentioned before, we have digital literacy and we have expert like all of you here. Why don't we just move together to do that, right? To involving the community, you just take your smartphone, you have your podcast, and you can just make it viral, right? Saying that please do not use antibiotic unless you are needed, for example. Right? It is very easy for you, right? And you don't need to wait the government to have the regulation about it. Thanks. Yeah.
Next question from this slide.
Okay, thank you so much for the opportunity, Pak. So my name is Jonisa. I'm actually coming as a researcher from I help University of Kent for research in one of it is zoonotic disease, and I think this is probably more of a hope compared to questions. In this in this course, I hope we discuss the challenge with local community and culture more, because in one of our research, we are trying to see the relationship between hunting and wildlife consumption in Bornean communities, especially the Dayak, which is a very big part of their culture, and also rituals. So, and that's definitely, as we all know, been discussed since this morning, that is a main threat, yeah, consumption of wildlife. But then how do we see it from cultural perspective? Oh, and actually I came from environmental anthropology backgrounds because of all this. I'm really interested to see One Health integration more with social scientists in the future.
Yep. Yeah. Thank you. It is maybe it is hope or comment, right?
Not comment, yeah, just a hope that we will discuss it more throughout this course, I guess, because cultural, not just in a Bornean community, yeah, but everywhere. I think it's very difficult to disengage from eating wildlife or like hunting practices, especially for communities live very closely around forests or wildlife.
Yeah, that is true, right? So why it need the multidisciplinary is because, like one example, we have a seminar, we have a discussion before about the cat lover. There are many cats in this campus, right? One of in the human point of view, medical doctors, they are saying that this possibly source of the zoonotic disease, right? And also from the vet, the same thing. They're saying that, yeah, please control the number of the cat in there. But when we asking for the social scientists, saying that, please remember, this cat might be stress relief for the students. Some of the students becoming lonely because they are far away from their family, right? And then they're starting to just cuddling the cat, right, like a pet, and then a lot of sudden another students have the same situation, and they able to communicate, and they have each other because they are loving the cat, for example. So that is the one example that the social scientist is also part of this One Health situation. Another example, we have anthrax in Yogyakarta. As I mentioned before, anthrax is related with the culture where people will consume the sheep or the cow that is becoming sick. Before it was died, they starting to slaughter, and then they consume the beef and the meat, and then they are distributing to the neighborhood, and the neighborhoods also buying the cheap beef, cheap meat, because in the social anthropology point of view, maybe people want to what do you want to help the person that lost their cow, because it is worth around 25 million rupiahs, right? So at least they can just donate it. That's the first. Then second is that for the people that is in the suburban area, maybe on the rural area, consuming beef not every day. And then now there is a meat that is very cheap, so they need to buy that one, right? So this is cultural thing, right? This is social thing. Then you cannot say then, please do not eat that one. Please do not do that. No, it is not the way we thinking and the way we act, because we need the social science expert to help them to understand that there is a situation where we are in the risk of the becoming transmitted bacillus anthracis among the people and also the cow that is sick, right? Yeah, thank you to raise about the social science here.
Okay. Should we have another quick? Oh, there's two.
Yep.
Who raised the hand first? I took this one. Okay.
Thank you. Good morning, everyone. My name is Rani. I'm from Indonesia. Prof. Tri, I want to ask, in our primary healthcare, like puskesmas or primary clinic, laboratory investigation or laboratory testing to confirm bacterial infections like CBC or bacterial culture are rarely performed due to cost effective and accessibility. And my question is, how can clinicians, especially general practitioners, can prescribe antibiotic rationally to prevent antimicrobial resistance due to this circumstance? Thank you.
Ya, Pak Edwin bisa membantu jawab saya.
Thank you, Prof. Tri, for your right. So we have to look not just by one side that this person is sick and we give antibiotics, but we have to see whether this sick person is infected by bacteria, and then we have to identify what bacteria is infecting this person. For example, pulmonary disease, pneumonia. So we have to check this person by checking the sputum specimen. And then we collect and we identify whether this sputum is indeed infected by the bacteria what we are searching for, example, Klebsiella pneumoniae. And then we put this into a machine and identify which antibiotic is resistant and which antibiotic is still sensitive. By there, we give this result to the clinician, and then this clinician will then decide which antibiotic is required for the patient according to the result we have given them. Is that right, Prof. Tri?
Thank you, Doctor.
The problem is in the primary healthcare.
In the
right?
primary healthcare,
Where the
for
is not present.
If there's not available in primary healthcare, we do have this system where we can send this specimen to a hospital where it has the capacity to identify and detect this bacteria. I think that's the only answer I can get.
Thank
Yeah.
you, doctor.
Yeah, the referral system is the answer maybe. And then actually in our system in Indonesia, we have a clinical laboratory in every province. We call it as Balai PPLK. Yeah. PPLK designed actually to serve that situation. So from the primary health care, you should not refer to the private, but you should refer to this laboratory. By design like that. Yeah, this is ways just to refer it to the referral hospital. Maybe. Okay.
Thank you, Prof. Tri.
Ya itu masih ada satu lagi, silakan.
One more from this room.
Thank you. Good morning. My name is Ahmad Solihin. You can call me Asol. I'm from Jakarta. I have question. In lab, especially biotechnology lab or microbiology lab, when we culture bacteria, sometimes we add antibiotic on media. The question is, they use antibiotics in labs for research or academics. Is it drive to AMR2?
Yeah, thank you. That is that's a good question, right? So sometimes the antibiotic we use is not only for the curative approach, right? Curative purpose. And of course, true, in our lab, there is need also for antibiotic. But you need to understand that actually every time we use antibiotic, every time we make the selection pressure. So make sure that if you use that wisely, you use that. Otherwise, it is going to be part of the selection pressure. Yeah, it is true. So that in that case, sometimes we use the antibiotic that is not really used in the clinic. For example, for the antibiotic for identification of the microbe, we use the antibiotic that is not used in the curative approach. Like for example, we use the bacitracin, optogen, or other thing, right? Because aside because they have the specific characteristics, so able to help us to identify, but they are also not in use in the clinical setting, right? Yeah. Yep.
Okay, thank you. And one from the online. Oh, this one more. Oh, so we still have 10 minutes.
Hi everyone. Sorry if I ask question again. So, you mentioned before, Prof. Tri, about the diagnosing tools and metric on the slide. So, you also mentioned a couple of times about the prevention, the importance of prevention in One Health. So I wonder if in the previous slide there is a diagnostic tools, which is to diagnose the situation, the condition by, for example, the metrics. One of the metric is the admission, the hospital admission, and the number of illness or disease. But is it possible, and would it be beneficial if we develop forecast tools rather than just a diagnostic tools? Because we already knew that I'm sure that we already map out like the high potency area. It depends, considering like different culture, like the previous questions already mentioned, like the urban rural situation will have different potential threats. So maybe is it possible for us to develop forecast tools to map out for prevention? So not only diagnosing when it's maybe already a little bit too late since the outbreak is progressing rapidly.
Yep. Okay, thank you. That is good idea, and it is already applied actually. For example, we we have many people that is working in epidemiology. They able to do the mathematical modeling to forecast, right? For example, if you see some of the reference, they always saying that in 2050 it is going to be 10 million people dead associated with the AMR if we don't have any clue to tackle down the problem now. For example, it is mathematical model, yeah. But when we saying mathematical model, so we still have we still need actual data. We need data to be analyzed, right? And then of course we can predict if we have the data. Yeah, it is true. I'm agree with you that instead of using only like a reactive one, right? Oh, there is a dengue now. Oh, there is a many laboratory positive for dengue today, misalnya. So it is going to be very late. But actually, people that is working in the, for example, district health, dinas kesehatan itu apa sih? Health district agency, usually they are working to predict that one already using the last year's, 2 years or 3 years data, and then they perform mathematical model, and then they able to predict the possibility that the dengue, for example, we know now the dengue have a 5-year cycle, for example. Yeah, it is because they count it from the actual laboratory data.
Yeah, but actually it's not only from the technical. Thank you. From the technical aspect, but also maybe we can also map out why this disease will happen, particularly in this area, because of different economical context, cultural context. So not only like forecasting, there might be like this disease in 2027, for example, in this country, but different local area, they have very different potential disease and threat, something like that, but more specifically, so not like general prediction, something like that with the mathematical model. That's actually not what I mean.
Yeah, it is true. Yeah, if we do able to do that, then it is good. But just want to add some information, like we have several area with the hotspot of anthrax, for example. We have Boyolali, Salatiga, and other. And then, of course, the sentinel surveillance will be concentrated in that area for the anthrax, but not Jogja. Maybe Jogja have another disease to be scrutinized every time, right? To predict that one. It is true, yeah. And yeah, we call it as sentinel hotspot surveillance, that one. Yeah. I think it is good to be discussed in this class, maybe. And maybe in there will be Pak Anis, yeah, that is going to teach us how to predict that one using the data from the epidemiology thing. Yeah.
Is it possible for one question, or I think that we have short of time. We have still one lecture. I mean, like one session. So I'm sorry. Thank you very much, Prof. Tri, for this insightful information about not just the disease, but how we actually need other intersectoral communication and information to response to the One Health situation.
Thank you very much.
Thank you very much.
Assalamualaikum warahmatullahi wabarakatuh.
Okay, for our third speaker, we will invite Prof. Showroom. It's actually a funny situation. I was invited to her workshop in Taiwan, and then I had a stupid question to ask her, and then we had a discussion, and then now she's here with us in this One Health forum. So I think we will see that she is a deputy director of the National Institute of Infectious Disease and Vaccinology in Taiwan, and also a general secretary of the National Disease Bank in Taiwan, especially in Mycology Reference Center, and she is a creator of the Candida tropicalis database. So we have around 40 minutes for fungal infection and in One Health situation. So the floor is yours, Professor Surum.
Yeah, terima kasih. And that's the only one I know how to speak. And thanks for inviting me again to share our laboratory result about the fungal infections. And this is one of the example to show you One Health issue, how the fungal infection lead me to involve in the One Health. And this is how to pronounce my name, Xiurong. Yes. So this is the outline I'm going to give today, and I'm not going to read it, but just go through it one by one. So this answer if you get the infectious disease, what will happen? You go to the hospital. The first thing is, as I say, it's very important to have the right diagnosis. For example, whether it's infected by bacteria or fungi or viruses. And how to do that is, I would like to emphasize, it's very important to do the epidemiological study locally, because you have to know what's the situation in your own area. The reason is that when I go back to Taiwan in 1999, I want to conduct the surveillance, and people say, oh, come on, the United States or Western country have done that. Why should you bother to waste money to conduct the epidemiology study? Then I say, well, my job, I was hired by this mission, so I have to do it. So after we do it, later I will tell you, we identify one of issue specifically in Taiwan, then later on is in Asia. So that's why, and to do the surveillance, you will know what kind of the susceptibility pattern in your area. So for example, if your patient is come to your clinic, you can say, wait, I have to get the laboratory result in 2 days, then I give you a prescription. So that is how we prescribe the medicine correctly, smoothly, is because we have the epidemiologic data. We know what kind of bacteria is susceptible to what kind of drug locally. So when you have the right medicine, are you home free? No. Sometimes you take a medicine, then there's have the microbial will have the mutation 1 to 10 to 6. They will have one mutation. So somehow the mutation will have some of less successful strength. Then when you use it, then it may become resistant strength. Then, you have to change it to another medicine, even though at the beginning, it is the right medicine. And the worst part is you got the wrong medicine. And then another one is actually you obtain the drug resistance from the outside environment or food or air. That's then you got a resistance, you have to change the medicine again. So that is one. And the One Health, I don't have to emphasize more, but I want to just say one thing is I put a plant in addition to these 3 parts. Okay, so why? Let me tell you a story. So this is the cause of death in the world in 2021. And the red arrows indicate the death caused by infectious disease. And for example, COVID-19 and TB and HIV. In TB, for example, every year is 1.2 million deaths. And if I say TB, I think everybody will not have said, yes, I know TB. But how about the fungal infections? So as I said, this is just like an example, tip of the iceberg. If you don't look for it, doesn't mean there's no problem at all. Just because we don't know there's a problem. So that's what I want to emphasize it. So what kind of patient will get the fungal infection easily is because most of fungal pathogens are opportunistic pathogens. So in the old day, because there's not many high-risk populations. Why? Because high-risk population including the immunocompromised patient. So for example, AIDS, chemotherapy, or those people. And before that, those people may die before they have the chance to get infections. But now technology and the medical care, so they prolong the life of them. Then they will have the immunocompromised status, and then it becomes easy and the risk population to be infected by fungal infection. And also, if you use invasive hospital procedure, you will introduce some of the passages, and also you got the antibacterial antibiotics. Why? Because you use broad-strain antibiotics, you kill all the bacteria, including the good one. And then the environment doesn't have the competitor for fungus. Then finally, the fungus have a chance to grow, and they will cause a disease. So the high-risk population increased, so the prevalence of fungal infection increased. Here's a number. About 6.5 million people are suffering from invasive fungal infections. Among them is about 2.5 million deaths directly caused by fungal infection. This fungal passage including the yeast or fermentous mold, and all the fungal passages. And so, as I mentioned, 1.2 million deaths caused by TB. This is almost twice more, but not many people know. That's why my job is, everybody invite me, if I have a chance, I just come. Because I want everybody to know fungal infection need more attention. And in Taiwan, we have the conduct, this is like is a yeast passages, including all different kind of species, but it's way higher than other bacteria. So, but if you cut the yeast to the Candida, this all red one is Candida albicans or other species, then you know it's compatible to bacterial infections. So when I come back to Taiwan in 1999, so the main mission is to monitor the trend of species distribution and the drug substance of yeast passage in Taiwan. So we conduct the epidemiological study of T-cell rate every 4 years. And this collection criteria is published. If you like, you can read. And so basically, we have this 4 years, the same criteria, and the hospital actually is almost the same set. You don't change hospitals because they may have a different data. Then you don't know it's because you change the hospital or it's a real trend. So here is antifungal drugs. And if you're interested, you can read more. So we just have a different kind of antibiotics, antifungal drug. And one I would like to say is a cell membrane synthesis inhibitor, azone. Azone is a drug for the invasive fungal infection. Azone is the only drug can take orally. So if you know what's the difference by orally or the injection, because orally you can be home. You don't have to be hospitalized. I don't know in your situation, but in Taiwan, if you have to get injection, you have to go to hospital. That makes huge difference. And this is a drug, only drug type of drug can use orally. And this is just, I love this kind of the slide. That's I just show you different color represent different type of drug, and this is a year how they develop it, just for your reference. And by the way, you don't have to take a photo or anything because this slide will be available to the organizer if you need it. But in the PDF file, you see, if in the other file, it will change the pattern. So if you like, you can ask for it. So now we do the susceptibility test, and that's all different kind of common Candida species. And there's several facts about this surveillance. First, Candida albicans is always the most prevalent one in whole wide world. But in the 20 years ago, it's 80% of yeast disease caused by Candida albicans. Now it's about 40 to 50%. So it switched from non-albicans species because the drug use is select for more resistant to the drug. That's a non-candida species. So one of these is Candida coolsii. This is intrinsic resistant to fluconazole. So if you diagnose Candida tropicalis, basically you don't use the fluconazole at all. And this one is Candida tropicalis that I would like to bring your attention is first, you can see is Candida tropicalis is number one non-albicans Candida species cause disease in Taiwan. And secondly, you don't have to really read the number, but you see the red things. Candida tropicalis has a more higher resistance rate than the other Candida species. Okay, these two things. And this one, I have been contacted for many, many years. It's so puzzle to me is that in 2002, there's no resistance. And then 4 years later, it's high resistance. And 4 years later, there's almost none. You know, the yes and no, yes and no. And it's very puzzling. But after 2014, it always have the red color, always detect the drug resistance. And then we would like to know is whether this drug resistant isolates among these 20 years are the same genotype, or each 4 years is a different kind of Candida tropicalis causing the disease. So, one of the methods called multi-sequence typing, because you only need to have 6 genes, and total is about 2,600 base pair of the sequencing. You can compare the genotype. And that's what Madhuri said. I'm the curator of this Candida tropicalis MLST. Okay, then that's what we found. To our surprise, the resistance strain after 2014, they're almost the same as CLAD4. It belongs to one genotype, and it's CLAD4 among these 3 surveillance. And before that, there's a resistant one too, but it's not belong to CLAD4. So we would like to know what's happening, why the CLAD4 is so persistent after 2014. And this is always, I would like to know is what is in your area or your country. Do you have a CLAD4 drug resistant Candida tropicalis too or not? And if you're smart, you say, come on, 2,600 base pair, and you can tell whether they are same genotype or not. I don't believe it, of course. So we do the whole genome sequence. So then the whole genome sequence also say the CLAD4 is very closely related. But whole genome sequence is very expensive, right? So after we prove that, nowadays we still use MLST to do that because it's cheap, easy, fast. So this is a drug resistant mechanisms, and you can tell it's a different kind of resistant mechanism. And there's a lot of reviewer, but I just want to show you is one is you don't let it get in, and if it get in, you pump out, and or you mutant the target, or you overexpress the target, or you bypass request of the target, or you have something to disrupt the drug. Okay, so I'll just tell you that is because later I would like to know is why CLAD4 is so persistent. What's the characteristic of this species, this genotype? And then I would like to show you is, this is busy slide, but it's color code. So here is a susceptibility. Whenever it's a R, red R means it's resistant to fluconazole, okay? And then this is a CLAD. From here is a CLAD4, and then there's other CLAD. Then the one thing is very obvious is ERG11 is the drug target. And you can see from the CLAD4 is all red because the target is mutant. So you know this is a mechanism contribute to drug resistance, but other resistance is wild type. In addition to that, Candida tropicalis is a diploid. Diploid means they have 2 chromosomes. One chromosome of ERG11 is wild type, because the wild type ERG is always better than the mutant one for the Candida tropicalis to growth. And another copy of chromosome, they have the mutant ERG11. And to my surprise, actually, I have to say, 10 years ago when we found it, I don't even know this is true. Because that chromosome have multiple copy of mutant. Okay, so for example here, the one copy is wild type, and another copy, the number is represent a copy of ERG, the mutant ERG level. The highest one will be go 9 copy, just copy, 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 and it's a mutant. So the drug will not recognize it, so this strain can be resistant. So you say why they have one wild type, one mutant? This is to make the CLAD4 very suitable for the environment. With the drug, they switch to a mutant part. Without drug, they switch back to the wild type part. So that, and also, lots of the resistant strain, they have some growth defect. Because, for example, the professor said the resistant gene in bacteria. Because, you know, if you believe evolution, they always choose the best genotype for the environment. If you have mutation, means they all, in order to survive the stress, they have the mutation. So most of the mutation strain have the growth defect. But for this CLAD4, in the laboratory condition, they go as well as the wild type successful strain. Okay, that's one thing. So then that makes the CLAD4 become so persistent, so successful, so suitable for the environment. So then is why it goes like that. There's two possibilities to let the CLAD4 become resistant. One is what I always say is if the patient take a drug, they may develop a resistance, or they got the resistant strain from foot, air, or hand, all the possibilities. So in order to distinguish these two possibilities, so I investigate whether the patient infected by resistant one has treated by other type of drug in clinical. So what we did is we reviewed the medical charts of those patients. And to our surprise, 2/3 of patients did not use other drug 6 months before they collected, within 6 months. So another fact is that the CLAD4 other resistant cancer isolated from all regions in Taiwan, not particular one area like is outbreak or something like that. It's all over the Taiwan. Okay. So this is a fact. With other drugs were used in human, animal, and the plants. And also about 80% of plant disease were caused by fungi. And then it's about 150 tons of other fungicides used in Taiwan every year. 150 tons, you know, when it go blah, then we all die. And so in these effects, I think it's at least some other drug were not selected within the patient. Maybe it got it from the environment or other places. Oh, I'm sorry. What did I do? So we conduct the surveillance in the environment. So we go the arches. So the purpose is whether other resistant CLAD4 exists in the environment. And also is whether different pathogens have a different preference between human and the environment. So we do we divide the one farm to 5 different areas. We collect the food, soil, and the water. And we also collect the unpinned hand and the oral rinse from the farmers. And I also asked the farmers, say, did you use other fungicides within 1 month before I collect the sample? So I always collect the sample, the food, ready to be on the market. Because the thing I say is, because if the fruit contains the resistant isolates, then you in the market, then you buy it, you may eat it. So that's the criteria we did. But now we do it every month with other purpose. So here is a color code. The green one is from human and the red one from the environment. So like I said, Candida albicans is most of them come from environment, especially is from the orals. And then the Candida tropicalis is highest species I identify from this surveillance, and it's also most of them from the environment, including the Candidococci, which is intrinsic resistant to the ozone. And we conduct twice. Actually, we conduct 3 times, but the last one I haven't got the permission to tell you yet. But then I show you 2 of these. So 2012 and 2018 from the grape, papaya, and the Watts apple, and you can see the resistance rate go to 24 to 62 or 10 to 20, and the Watts apple is very less isolated, so we don't think this is statistical significance. But when you see this, the grape is the issues, and also most of them are CLEF4, which is a genotype caused disease in humans. So we analyze it, the resistance rate increased significantly, and as I mentioned, I asked a farmer to give me information whether they use other fungicide before I collect the sample. And in 2012, it's about 6 farms, is 35% of a farm use of other fungicide. But in 2018, it's about 82%. They all use other fungicide. Maybe that is why the resistance rate go up in 2018. So is this just case in Taiwan? No, in Taiwan, yes, we first published, and China follow up is the case. And the CLEF4 resistance also detected in Australia, India, Singapore, and Thailand. And in Indonesia, recently their publication is say drug resistant one, but they haven't determined the genotype yet. And the Japan also has a drug resistant. Both of them haven't detected the genotype, but I assume it might be the CLEF4. So, yeah. And we do the environment. Oops. Sorry about it. So then, we would like to know is how, since CLEF4 is so predominant among the drug-resistant cancer class, can we develop a rapid diagnosis method to find it? Yes, we have done the multi-process PCR. Then we use null-pol sequencing and do all the bioinformatic assays, so we can do 96 samples at one time. And I have a student who is a bioinformatics expert, so that actually now after we got it, my lab member doesn't need to use eyes to determine the sequence. So we have all different kind of the fancy thing, the AI thing. So then we can analyze that. So this is because we have the pattern. This is how my students write how the market and blah blah blah. So, but anyway. We want to know the first thing. The fact is, CLEF4 genotype is a predominant genotype among the other resistant. But how about the CLEF4 itself? Is most of CLEF4 is resistant, or actually CLEF4 half resistant, half sensitive? So we had to determine that, and we use the method we develop a rapid diagnosis. Then we found out the conclusion is that majority of ozone resistance belong to CLEF4, that's we know before. And now is most of CLEF4 also are ozone resistance. For example, here, we have the 39 isolates, and 32 are resistant, and 7 successful. But among 7, 4 of them is one step toward the resistant. So means if you can diagnose the CLEF4, you basically can know it's infected by drug-resistant isolates. So that's So as I said, we did a lot of whole genome sequence. So my student analyzed it, compare the CLEF4 and the non-CLEF4, whether we can use one of the genomes SMP to diagnose. Yes, to our surprise, we only need 3 SMP within 2 genes. Sometimes it's too good to be true, because it reached to sensitivity 0.98, and the sensitivity specificity is 0.9. So when my students show me that, I say, I don't dare to publish this data because it's too good. You know, it's almost 1. How can be like that? So then I asked him to check the Taiwan isolate and the global isolates. So now it's not just Taiwan isolate and also global. So the result is like that. Then I said, okay, I can publish it. So with that, he also do this kind of fancy thing, so we can just easily to diagnose whether it's a Cat4 resistant, and so that's the way. And because there's some technology already applied for using DNA PCR to identify the species, but now is we not only identify species, we also can identify if it's characterized whether it's drug resistant or not. So. The summary is that we have conducted local surveillance and we identify one issue, Canada tripicalis. And then since I'm the PhD, so I use my knowledge to understand the resistant mechanism, where is the reservoir, how to transmit. Then of course later we would like to make a policy to control it. So this is there's in addition to ozone, there's also other drug that is on the way to use both in agriculture and the clinical. So one of my job is to, as a policymaker, to think about it when you give the permission of those drugs that have the same action of mechanism, the same as medicine, and maybe you should preserve that for the medical use. To be selfish of our human being benefit. So the take-home message is, I did the patient in the TSRE and also agriculture, then we know this, then that's why bring me to One Health. So I think the clock is tickle. So we have to act faster and together. Because I show it's not only Taiwan issue, it's also Asia issue. I think it might be the issue in Indonesia too. So please, let's work together. And here, that is pesticide use in the world. And this is Taiwan. We use about 14 kilogram per acres pesticides. And here is Indonesia. You guys are much better than we. It's half of the amount. So, but we still can work together and to see, because a lot of other countries, you know, they use much less. So let's see whether we can work together to control the pesticide used in agriculture, especially the ozone one. So in Taiwan, and I don't know in this country, in Taiwan, at the beginning of fungicide, we don't label anything. Just say, just the name of the fungicides, pesticides. And the farmer just go to the pesticide store and say, blah, 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 then they give you there. So one day I visit my professor in the university, and he gave me very, very, very expensive herb medicine called Linzhi. I don't know. Anyway. And he said, oh, test some. I said, oh, that's expensive. How can you have it? He said, because I saved one tree for the millionaire, and that tree was then $1 million NT. And I said, how can you save it? He said, because that tree was infected by bacteria, but the drug store give them the drug for the herb, for the grapes. So, of course, it's not cured. So when I diagnose, I change the pesticide, then that tree go happily. Therefore, he sends me with this very expensive Chinese medicine. Okay, so this is an example, because the farmer, they don't really know what it is. And so we propose on the package of the pesticide, at least you should label some like action of medicine or mechanism, or what kind of target. Is that for the insect, or that is for the herb, or that is for the fungus, right? So finally, in August of 2019, our government changed the regulation of label of the pesticide. I mean, the package of the pesticides. So this is F, responsible fungicide, I stand for insecticide, and H, herbicide. So at least the farmer know what kind of the pesticide they used. And it's even more important is they have the action of the mechanism of action of the drug. These three, F is fungicide, these three represent other fungicide. So for me, it's very easy to communicate with farmer now. Actually today is my colleague went to my collaborative farmer to collect the samples. So I can just go to the farmer and say, would you please not to use F3? If you use others but F3, I pay for you. However pesticide you use, I pay. And they're very happy. And they know how to do it. F3, no F3, no F3. Then that's so easy. So this is only one action can make things very easily. Then you say, how long did it take us to make a government to make announcement about the regulation of the label? 30 years. 30. You know, for people like us, it's come on, so easy. But you know, when you go to reality, it takes 30 years. But you know, don't give up, because if you give up, it will not happen. But we just push. Finally, you know, people, I mean, our government do it. So this is acknowledgement. So we have a TISA hospital, of course. They are very kind to collaborate. You know what? Because we only pay very, very little money for them to collaborate to help us. And they have been helpful since 1999. And this year is the year we collect again. And we have, oh, I'm sorry. We have the Steel Committee. Steel Committee is good is because my founder director going to retire many years, maybe 20 years ago. And he was very powerful man, you know. Then whatever he said, people will say, okay, yes, right? But he retired, become the little person like us. Whatever we say, nobody will say, oh yes, no, So before he retired, I went to his office. I say, you know, you're so selfish. You enjoy your life and you put us in a difficult situation. And he said, okay. Then I formed the Microbial Infection Laboratory Steel Committee. Okay, those members are all the very powerful person in Taiwan. So we have the backup. So then we report to them every year. What's the situation? How to do it? And is this a collection criteria okay? And they say okay. And including this one, it has the same last name, so it's very nice and helpful. And he is a military of CDC now. So, you know, he knows everything about what I did. So it's very easy. Why in Taiwan I can put a plant in the One Health? Because I keep brainwash him. And now he speaks for me, right? So then I say this is so important. But if I say that, people say, oh yeah. But the director of military of CDC, he said that everybody said, oh yes. So that's why last year I can push the government to add the plant in the big project. Last year we had a huge project to support One Health research. So finally the plan was stick out. Otherwise, before that, I didn't say human or animal or ecosystem is not important. They are very important. But I just want them to remember plant section is also important. So finally they take my voice because I speak very loud, right? Blah, 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 blah. So then finally they take my voice and they put the print. And NHI, if you had chance to visit NHI is very, very unique research institutes. It's a mission-oriented research institutes. Because the epidemiology I did is impossible to conduct in everywhere, because you have to do it every 4 years, and without the publication, publication is not a major issue. To do the local epidemiology is the mission for me. That's why we can do that and keep doing that. And also is NHI have the A Research Institute and other research divisions. They have all different kind of experts. So for example, these two are bioinformatical persons. At the beginning, we do the whole genome sequence of 2 diploid of a chemotropically. They even cannot assemble it. Because the 2 chromosomes, I can tell is A chromosome or B chromosome, blah, blah, blah. So we have the bioinformatic person who really work hard with us so we can solve the problem. And this is my colleague and who do the non-pore sequencing. Okay. And sometimes you have to do the good thing without selfish purpose, but later on it's payback. You know why? Because when I was a deputy director, I give myself a job. I say, okay, now what should I promote? So I promote the non-pore sequence in my institute, and I would like to persuade the real-time surveillance of antimicrobial resistance of microbials, because now it's a sequence year. You have to catch up. You know, not to say genotype or GATC speaks everything, but it's very helpful to predict. So at that time, maybe 12 years ago, I pushed that and I support that. So then my colleague is, it got only one center go, Excellence Laboratory of Non-Pore sequence, and given by the non-pore sequence company. So we are very, very good at that. And this is also bioinformatics, because sometimes my staff analyze the data, say, oh, this is significant. But I was so worried. Oh, time's up. Okay. So anyway, and this is for agriculture, and it is funding. So thank you again, and thanks for collaborator. And I want to say this actually is a character of Chinese. This is a single. But if you put 2 single together, you will not feel lonely. So that's why we work together. And that's it. Thank you.
Thank you, Professor Ru. Now we know that it's not just a human or animal, but plants are also important for one health and infection, not just by bacteria, virus, but also fungal. So I think we have 10 minutes of your Q&A. So anyone in this room would like to give a question to Professor Ru, raise your, which one?
Okay, thank you for your insightful presentation, Prof. You saw that fluorocanose resistance in Candida tropicalis has increased over time. From a laboratory perspective, what is the most important step we should priorities to prevent antifungal resistance, improving diagnosis capacity, expanding susceptibility testing, or strengthening molecular surveillance? Thank you.
So what is important for laboratory? One is to diagnose the species, or to know whether it's drug susceptibility. And the third one is molecular, the genotype. Okay, so for me is first, the 96 well thing. So you have to know what your enemy is. So definitely you have to identify it first. Now identify is very easy. So they are have the corn agar. You can tell the color of the colonies. But you also can do the simply PCR of ribosomal DNA. That's also within like a day you can do it. And the susceptibility testing is for some laboratories, they even didn't have an established method yet. Even in Taiwan, we don't have, not every lab can perform the susceptibility test like the bacteria. So, and for us, it's nice is we are the reference laboratory. So we do the surveillance. Then we tell the whole community, if you find this species, you have to be careful to see whether it's resistant or not. So for us, it's very simple. The Kusi, we know definitely you don't use a flucloxone. For the Canatropicalis, you know it's about 10 or 20% is resistance. The other species, okay, you don't have to worry too much. So that is a key point of our local epidemiology. So that, but for the Western country, I don't know in this country, Canada gubbata is one of those issues for flucloxone. But for us, luckily, it's okay. But it's gradually increase resistance. So the epidemiology is important to tell you what's the pattern here. Then everybody will know, oh, in my country, which drug I can prescribe and all those things. And the molecule genotyping is when you have a resistance, then you want to know whether it's outbreak or whether it is circulate in the country. So that it will be after you know the resistance is an issue in your area, then you do that. And of course, if you want to have a publication, that's another, is just for your curiosity of science, that's okay. But for the benefit of patient, the genotyping is not so important. So in my lab is we develop a method to do the ID and the genotyping at the same time. So that is that's what we did. Yeah.
Okay, thank you. The other one that raises the hand, that one. State your name and where you come from.
Hello, my name is David. I am from Palu in Central Sulawesi. Okay, thank you, Professor Showroom. Okay, in your recommendation, your research recommendation is use the different kind of therapy for plant, animal, and human, right? Okay, how if we just have one drug of choice of the therapy for human and animal? Okay, in the case of the cystosoma, we just any one therapy is talk about praziquantel. I need your perspective from One Health approach. Thank you.
Yes, I have to say is we are human beings. Huh? We are not more important than any other beings. Okay, so in case it's only one drug for plant or animal or human, I think they should be used for all of them. But what I say is for the agriculture, for example, let's guess how many percent of the fungicide you use go to the target. Do you guys know? If you use 100 gram of the fungicide, then you spread on the farm, how many percent of that really go to your target? Want to guess? 1 to 10%. So 90% of that actually doesn't go to a target. They just in the environment, you know? So for me, if that is one drug, for the animal, it's easy. You just go to the animal, right? You don't, unless it is a fish, you go to the pond or something, right? So you have to use it, but use it smartly. Not like not like a spread like that, right? You can maybe inject in a disease area. That's for plant. But for the animal, I think if it's sick, that's the only drug we should use it. So I didn't mean that you should not use. For ozone, I graduated from Department of Plant Pathology. So when I present my data to my steering committee, who are all the MD, right? He said, sure, go to agriculture, tell them not to use ozone drug. I said, no, because the farmer want to harvest their crop to survive. You can. But I will tell them, don't use it for the prevention. You can use other different drugs for prevention, right? But when it's really, really disease, that's the only drug you have to use. Please use it. That's why I go to the farmer. I say, actually, that's real. I say, can you divide your farm to two parts? One is ozone-free. One is whatever you used to use. But if you see the experiment one, the ozone-free, it's not good anymore. I have to use ozone. Call me. Then please use it and recall it. Because if you want to persuade someone collaborate with you, you can't let them not to have a benefit, you know. They have family to raise. So I say, if everything's okay, please do not use ozone. But when you find out you can't do anything to prevent, to treat the disease, go ahead, use ozone. Then we will, after this thing goes, then we start again. You know? So this is a way to respect all the beings. You know, not the animal, plant, all those things. Yeah.
Okay. All right. So, does anyone in this? Oh, yes, one more.
So on the walking, seen about 150 tons of fungicide. You know, it's only very few go to the target. So the reason I just want to tell the government not to use so much ozone fungicides. And you just rotate it or reduce it, not completely stop. Because if you know, how to make the policy work is you have to generally do it. Because the farmer will not accept it. I went to so many farms. If elder one say, I have more experience, I don't want to listen to you. So my target is a young generation because you can communicate. But if the young generation goes well, then the old generation sees the neighbor, maybe he will change. So you have to find the right target to work with. Okay, sorry.
So thank you for the opportunity. I'm Asha from North Bali. I'm a medical student at second semester. So a while back, I was learning about fungi in my class. And then I just read that there was a report about a case of coccidioidomycosis or valley fever in Taiwan. So how did the medical community there respond to the emergence of this fungal disease, and which is usually found only in desert regions? Is there a specific program or centralized database that funds intensive research or addresses the spread of fungi?
Yes. Thank you very much. So this is belong to biosafety level 3 or 3 plus or 4, for 3. So in our institute, my government, when COVID happened, and we realized we don't have a national infectious disease bank collect the very important microbials. We are only focused on whatever we surveillance, but we don't have the national data bank. So the government just asked NHI to establish the National Infectious Disease Bank called NIDB. I happen to be in charge of that. Okay, so after that we build a building. And we have a BL3 laboratory. Unfortunately, not finished yet. We are going to finish by end of this year. We can operate next year. But for the biosafety level 3, we do have another laboratory at the NHI. So we do have a meeting about that part. So we say, should we study that carefully? Yes, we prepare that. So we do an analysis. I say, well, first, we have to use BL3 laboratory. You can ask other lab to work on that. So the first. So if the government really asks NIDB to do it, we have to borrow the BS3 lab next door to ask us to use it at first. That means if government really want to do it, we can do it because we have a BS3 facility first. And second, we happen to have the expert, my colleague, who is more expert. So she prepared that, and actually, few months later, she gonna present how to react this in Taiwan. So we have the person who can do it. Like NIDB, I have to train at least 2 people has the experience to handle BS3 microbials, and I have to train another 3 people on the class. Not really doing that. 3 people. And I also went to the class like this for 3 days. So then we are prepared for that. Not only in this species, other viruses too, a lot of other viruses. So we have prepared for these things. So we have this one of the center that we can do that. But be careful, right facility. Because we don't, and also that is not very common in Taiwan. So we say if this is just one case, let's just prepare it. Don't really make a big deal. If the second come, then at least we are ready to do it. That's our action now.
Okay, I think the time is up. Thank you once more. Give a round of applause for Professor Shoru. And at the end of this first session on today, I'd like to not round up actually, just giving a summary on how important that emerging disease, fungal infection, and also the health implementation is quite important. And of course, how we have to interact with interdisciplinary to to respond to One Health situation in our countries, not just Indonesia, not just Taiwan, and how we can make that as a one method to develop a policy and helping us to prevent further infection or emerging disease. Okay, so this is the end of this session. I'd like to say thank you very much for the attendance on this room and also on the online. Sorry that we cannot accept more questions because of time. So I think this is the end of my session. Thank you very much for the attention, and I'll give this back to the Master of Ceremony to present more of the information on lunch, I think. Thank you very much.
Okay, thank you, Dr. Edwin, for guiding us through this morning session, and also okay, and we would like to invite Professor Shulung and Dr. Edwin. We want to give our appreciation, a little appreciation for this morning session. And maybe Dr. Farah, as a chairman of this organizing committee, will give the appreciation for our first moderator and Professor Shulung.
Thank you. Thank you.
Right. UGM sign. Okay, thank you, Professor Shulo and Dr. Edwin. And thank you for all the speakers, or maybe Dr. Nafnet has left the Zoom, and for Professor Tri and participant for this enriching morning session. And now we will break for a lunch, and the lunch has been prepared outside of the room. And the program will resume at 1 p.m. So please kindly return to this room promptly so we can continue the schedule accordingly. Thank you, everyone.
Progress.
Klik kanan terus keluarin aja langsung. Cek. Cek.
Good afternoon, everyone. I'm sorry if I startled you. Welcome back, and I hope you had an enjoyable lunch break. And maybe we still have our friends on a prayer break. So until we hear with them, maybe I want to share about a bit information about ELOC system. Has any one of you already know about ELOC system? The learning platform that we will be use, and if you want to get a certificate, you must complete all the learning session in this ELOC system. Oh yeah, nggak apa-apa. And I would like to inform you a little bit about ELOC system, that in this program group, have anyone, all of you see the program book? There is a barcode, and you can scan the barcode to get the complete information about ELOC system. And maybe some of you already finished the pre-arrival assignment. Oh, you haven't seen yet? Yeah, I see a pre-arrival assignment that will due to, it is due today. I mean, not this afternoon, I mean today. Or maybe you can fill the, complete the pre-arrival assignment first before the day end. Right, so this our afternoon session, we will be focused on the theme of human health, surveillance, and digital innovation. This session will be led by our second moderator, Dr. Rernat Abdul Rahman Siregar, Bachelor of Science and Master of Biotechnology. Please show the resume of Dr. Abdul. A brief resume about Dr. Abdul. He is a lecturer in the microbiology Department of Tropical Biology, Faculty of Biology, Universitas Gadjah Mada, Indonesia. He is also a member of Academic Senate, Faculty of Biology, Universitas Gadjah Mada, a former guest scientist, Infection Biology Unit, German Primate Center, Germany, and also a former guest researcher, Laboratory of Stress and Applied Microbiology, Nara Institute of Science and Technology, Japan. Please join me in welcoming Dr. Abdul Rahman.
Okay. Assalamualaikum warahmatullahi wabarakatuh. Yeah. Good afternoon, everybody. Is everything okay? After having lunch, sometimes we feel very enjoyable. Yeah, to have the next discussions. And yeah, without further ado, welcome to this session. And this session we will have two very outstanding experts who will share their insights about public health, surveillance, and also pathogens emergence. And we are very happy, we are very fortunate because we are having these kinds two experts. The first is Professor Nelson Martin from Timor-Leste, and the second one, Dr. Ahmed Abdul Wahid from Leipzig University. For the first session, for the first terms of this talk, for these sessions, Professor Nelson Martins will talk about surveillance and their roles in the first is detecting, monitoring, and also controlling the public health threat, as well as the role of early warning systems, to prevent or to protect the spread of pathogens, the spread of disease, and also to protect the community. In his talk, Professor Nelson will talk about that. And before doing that, before we come to the first term, I would like to give some resume from Professor Nelson Martins. He was a former Minister of Health of Timor-Leste from 2007 to 2012 and President of the National Commissions of HIV and AIDS. The second is a founder of SISCA, Integrated Community Health Services, and lead architect of the 20-year National Health Strategic Plan from 2011 until now, until next 2030. The third is founding director of National Tuberculosis Program, or NTB, and key contributor to the establishment of the Cabinet of Health Research and Development Ministry of Health Timor-Leste. And he's also a principal investigator of 23 health research projects and the leader of the Timor-Leste first randomized controlled trial, or FITTCET, published in British Medical Journal. Unfortunately, Professor Nelson Martins cannot come in person together with us here, but nevertheless, still we have a very modern technology. We still keep contact with him via Zoom. And please joining me in welcome Professor Nelson Martins via Zoom. Professor Nelson, am I hearable? Belum join ya, Mbak? Sudah join. Okay. Professor Nelson, am I hearable? Can you hear me? Okay. Please unmute your microphone, please. Because we cannot hear your voice. Mungkin bisa dikontak, Mbak. Beliau sudah join ya? Sudah join? Sudah, oke. Oh, oke. Professor Nelson. Sudah responnya, Pak? Belum? Can you unmute your microphone, please? Yeah, sorry. We still have to wait. Yeah, sometimes the technology is very helpful, but sometimes this case always happen. Belum bisa? Ya. Oh gitu. Oh. Yeah, I think while waiting for Professor Nelson's, maybe we can use this time to have a little bit discussions about the importance of surveillance. Does anyone here have an experience in working on surveillance before? No? Surveillance for public health and yeah, for example, like detecting, monitoring, and controlling the public health threat in order to as well as the early warning system role, yeah, to protect to prevent the disease spread as well as the what is it? Yeah, to keep the society, to keep the community health. Yeah, does anyone here have such an experience about it? We're waiting for Professor Nelson. No. Oh, does anyone here have an idea what is surveillance? Okay, anyone here? Any idea what is surveillance? Yes.
Okay. Uh, so when there was a COVID-19, so I was in bachelor's. So I had a project on the surveillance of the COVID-19 detection. Actually, it was in the Mexico City in the metro line. So whoever does not wear mask, so the cameras detect him, and then the many people who are like in charge there, so they catch that people and like fine him or something, like how to say that, to make him wear the wear mask, and that's where they can detect and then stop the spread of the COVID-19 in the Mexico City, in the metro line where the people used to used the public transportation.
Okay, so you used to have an experience doing that in Mexico City.
No, I have done a project like a remote project on that.
Okay, remote
how
project.
does public health surveillance works.
Okay.
Yeah.
So this for Mexico case. In Indonesian case, do you have any idea of any experience in surveillance? No? I think if you have an experience, right, something like screening for entering some public places, sometimes we have to do some screening, yeah, and it's also one of the surveillance approach that we can use so far. And from that, yeah, the responsible maybe the responsible council or responsible body will have the data, then we can, and they can make some conclusions about what they have got so far from the screening. Yeah. So thank you very much for your opinion. Any progress from Professor Nelson? No? Sekretarisnya, okay. All right. So we're still trying to get contact to Professor Nelson. Okay. Professor Nelson, can you hear me?
Hello.
Hello, finally. Thank you very much. Yeah, thank you very much for joining us here. So I've already introduced you to the audience, and without further ado, maybe it's better for me to give this floor to you. Professor Nelson, time is yours. Are you ready?
Okay, thank
Okay.
you very much.
Great.
Sorry for this the IT problem. I was actually mute and then can't connect, and then we have an internet problem here as well. So good afternoon, everybody. Thank you for moderator for this humble introduction. My name is Nelson Martins. I'm a medical doctor by profession. I was graduate from Pajajaran University, Bandung, in 90, and I have a PhD in tuberculosis and public health. So I think I should start with thank Professor Tri Wibowo for inviting me to attend the summer course to organize UGM. And my topic is public health surveillance and early warning system. Since this topic is very broad, and I hope that the participant, all of you, probably have a little background in epidemiology. And the terms that we'll use here is mostly public health terms and epidemiology. So I'm currently a professor at Menzies School of Health Research, Charles Darwin University, and serve as a senior technical advisor for Menzies at Timor-Leste. Can you hear me? So, sorry. Just to check my voice. Hello? Very good. Thank you. So, let's start with the first slide. As you know, that before I have sent about 8 references and about public health surveillance as well as e-words. Hopefully you can read. And with this presentation, I hope that by the end of the presentation, you can define at least what we call public health surveillance and early warning, e-words. The second, explain about the objective and core function of the surveillance system. You can differentiate it, the major type of surveillance system. And you can describe the key component of e-words. We're talking a little bit about internet surveillance and apply surveillance concept to outbreak detection, as well as recognized model for integrated surveillance. And probably we can include as well with the new development of EI, which is shaping the era of public health surveillance currently. The next slide. And yes, I take all of the reference from very old book. You can see from CDC there, which is firstly defined about the public health surveillance. But as you all know that surveillance itself it's emerged it's very long time ago since the era of Dr. John Snow. Okay, let's start from what is the surveillance. I think as defined by moderator before, you know that public health surveillance is the continuous systematic collection of data analysis, interpretations, and dissemination of health-related data, which is the need for planning and dissemination, implementation, and evaluation public health program. Basically, it's quite similar to research itself, But the key characteristic here is about continuous, systematic, and action-oriented. So those of you who familiar with the research, I think you have conduct all of this, except the differentiate the differences between surveillance and research. Surveillance is continuous. We establish the system and then we continue collect data regardless what happened. And for research, we hope that the policymaker will use it, but for surveillance, they must be used to take the action. So it's action oriented. And historically, public health surveillance only apply for infectious disease. As I mentioned before, I will give you later in the slide about what happened in cholera, restart infectious disease. And later on, through the development, surveillance also apply for non-CDCs, for nutrition, maternal health, mental health, and now the trend issue in One Health is about AMR, antimicrobial resistance. So next slide. And this slide is about the very early public health approach that implemented by John Snow to understand what is the cause of cholera. John Snow, as you know, that it's been regarded as the founders of public health and epidemiology. He's very famous, Dr. John Snow. I hope probably some of you already know about him. You know, during the cholera in London, people believed that the cholera was caused by miasma, by the bad winds or bad air. But after John Snow conduct this simple surveillance by visiting house, then identify the people who died at the time, mostly in the board street, near the water pump. And then he took action to stop people from collect water from this pump. And then he managed to stop the cholera outbreak at the time. So this is very simple public health surveillance activity, and then he's regarded. And this is in London. And the second slide, the next. It's this one is I took from one reference I sent you, a book about public health surveillance, which is written mostly by medical doctors and member of the BRIN. Indonesia, and it's the example of the surveillance of nutrition. How now the surveillance and how to detect, undernutrition in the to prevent the malnutrition in Indonesia. So it's very good example of how every step start from posyandu to puskesmas and to the pusat, all the steps from data collection, data analysis, and data interpretation, and also for action to be taken. And then I think you have many different surveillance system applied in different area, and then you can revisit it. So next slide. What is really the objective of the surveillance? As you all know, it's very broad. Everyone knows that the core objective is for early detection of epidemics and outbreak. Most of us, I think, including all of you there, we have just experienced recent COVID-19 pandemics, which is, I think, in every corner of the countries or the cities or village, we apply all of these surveillance to early detect the cases and treat them. The second is for monitoring a disease trend over time in the place. Like if you come to the place with endemic disease like dengue, malaria, diarrhea, or others, I think surveillance is very good to monitor the disease. You set the threshold, and then once the cases is increase above the threshold, and you suspect this will be outbreak, and then you remind the official to do intervention quick. The third is about identifying objective is high-risk population. You're talking about TB and if hypertension and risk factors and in population. And with the surveillance, we do the surveillance, we can detect early and then prevent the people from the risk of dying early from this kind of disease. Include malnutrition, I mentioned before. Evaluating intervention, example, vaccination program. Whether you want to know that the current program is is well implemented, you can do a seroprevalence, sero survey, and then to identify the effectiveness of vaccine. And surveillance can be used for informing public policy, triggering outbreak investigation, guiding resource allocations, and supporting international health regulation. The last one is very important. As a country, we must report every unusual disease or symptoms that emerge in our country. So what is the benefit of the public health surveillance? As you know, we estimate the magnitude and distribution of disease, identify population at risk, as I mentioned before. We can monitor the trends and detect change over time. And even in the normal situation, if even from the health data, if you notice anything goes on unusual, make sure that you alert and then make a reassessment. And assess the effectiveness of intervention. Any intervention that you do, surveillance is very helpful. And support evidence to decision making. Okay, next. Now I want to, this slide is very good. If you want to design surveillance, we have to understand what is the good surveillance system should be. The first is should be simple, simplicity. You make it simple that everyone, even like people, your health staff working in the very remote areas or very lower level of the system, or even uncommon people can understand this. I give you please remember again about the COVID-19. Flexibility, it means once you, it's very important that once you start, you issue the surveillance, it can be flexible to improve every time or change if it's not working. You have to ensure that the quality of the surveillance, the data or the definition or any or the terms that you use must be, the data should be quality in the collection. And acceptability, it should be accepted in all level of the health system and by different profession as well. Even in the health, we have a different profession. You're talking about epidemiology, you talk about microbiologists, you're talking about clinician. We have a different way of accept the definition. And sensitivity and post PPF, PPV. It must be validity. You have to, from the data, must timelines, it must be in time, according to the time, the real time, I mean. And stability, it means that if once established, if you want to the surveillance to report every week, make sure that every week you receive the report about the surveillance. So we're talking about the same data, the same information you receive. And good health system can be used for evaluation, meet the objective of the public health and also public health function. We have 10 public health function here, 3 public health function, and then 10 services of public health. It must meet this function. Next, I think this is the graphic is just the step of the surveillance, similar to the research, defining the problem, collecting the data, entering the data, processing the data, and interpreting. It's part of the analyzing the data and reporting the result. You can report to different actors and to take action. using the result to plan prevention and treatment, after that taking action and evaluating again. So these are all the same cycle, the step that going back and it must be working, continues working and to improve it. The next slide, I think this is the slide is more important, for this session. We talk the type of surveillance. We have, we divide this into the 5 main ones: passive surveillance, active surveillance, sentinel surveillance, syndromic surveillance, and evidence-based surveillance. So in normal situation, we implement mostly is about passive surveillance. So it's like we establish the system and let the data be collected through health facilities, routine reporting to health facility. It's low cost, wide coverage, limitation, under-reporting, and delayed data. It's under-reporting because later on I'll explain about it. Active surveillance is regular outreach to health facilities, high sensitivity, resource incentive anyway, common during the outbreak of pandemic. We have sentinel surveillance, the surveillance that we apply in certain groups or certain health facilities. It's actually just example, we want to see cardiovascular risk in the cardiac unit. We do specific for this in this area. High quality of data because it's very specific. Used for influenza HIV and MR, it's example, unable to detect outside side, so that the limitation is this. Not useful for rare condition. And syndromic, as you know, syndromic is come from syndroma, used for symptom. Sometimes we just check the symptom like fever, diarrhea, rather than diagnose the disease. It's just warning for early detection and particularly useful for laboratory capacity is limited. Like if you don't have a good microbiology for infectious disease, and then you can use syndromic surveillance. Later, evidence-based surveillance, actually called evidence-based, but mostly it's about rumors as well. When you hear some information through the media or rumors or hearsay in blog discussion or community report, and then you must aware, and as epidemiology, you must aware of this discussion and then try to assess and make sure that whether the rumor is true and do risk assessment. It's used to detect unusual health events from formal or informal what's called event-based surveillance, event. So basically, this is the type of the surveillance. And next slide, I just explain about what is the passive surveillance here. You can see there and different type of noticeable disease registered in the hospitals and hospital data, birth cohorts, all of type of passive that we can collect. Next slide. I hope I still have time. So nowadays, people, we focus more on active surveillance. As you know, we active. From the language, you can see active. We do more active to find about case finding, active case finding for outbreak. And we do serosurveillance, as I say, taking blood, and we do health survey as well. It's good for surveillance. And nowadays, people use more advanced genomic surveillance to see the type of the genomic of the different cause of disease agent. So active. And next slide. Yes, this one I just give you example about. I have friends here. We also do this study about the measles. This seroprevalence survey, you can see that after we do sero survey, we found that in the middle, I can't show you, but the lower case in blue, it took actually from the 8, 10 to 14. children. And this study, we found that actually the IgG or the immunology of children is very low, and they have a high risk for measles outbreak. And we use this finding to alert Minister of Health, and soon, very early, very quick, and Minister of Health with partners reintroduce new measles vaccination to give a protection to these children. So this is a simple example of surveillance that we did in Timor-Leste. Next. And syndromic surveillance, as I say before, if you have a very limited or underdeveloped laboratory or microbiology in your country, or your setting, or in facilities where you work in very remote, you don't have anything, you can use syndromic surveillance to track and to this disease, the outbreak, and report quickly to receive intervention. Next slide. Yes, I give this example about the component of ethnic surveillance, but very important is a standard case definition. The rest you all understand, we can just, I have explained before, but in any surveillance system, you have to define clear what is the cases, what is the suspect, and what is the confirmed cases. Even the standard case definition is different between epidemiologists, between laboratories, scientists, and as well as a clinician. We have a different definition. But to make sure that we all agree that one definition, our example, COVID-19, very quick and very soon, everyone just agreed with the definition. What is suspected case, what is probably, what is confirmed cases. So this is the important of the component. One is data collection, data analysis, feedbacks, and dissemination, interpretation. So these all make sure that in one system that you want to design, you make sure these all components is included there. The next, this is example that I give an example from Timor-Leste, how the government respond to the COVID-19 pandemic. And since we have a very weak minister system here to respond to a great pandemic like COVID-19, so government need to establish the system, the new structure to respond to the COVID. But if you look at the lower graph in black and white color, P1 until P9, we use the WHO 9 pillars, so implement. P3 is about surveillance and active case finding surveillance. So I was responsible for P3. We track any disease in COVID-19 suspect case everywhere, and to send to the health facility, which is managed by the P4. And this is example. You can read the case study I sent to you through Ibu May, and hopefully you can read it. It's also available in the WHO website. The next, and one of the things about surveillance now is previously surveillance was used manually, like you just collect the data, write it down, and then just Jon Snow, example of Jon Snow did in 1854. It's very manual, and he's just doing it by himself. And then now we have a digital and real-time surveillance. And we have tools that here to help us. You can just visit the DHIS tool. Now use a mobile phone for reporting application, dashboard for real-time, and GIS for mapping. All of this tool is really helpful, but you have to understand that it continues depend on us, human epidemiologists, to really interpret the data, analyze, and make a right interpretation about what is the data shows. So do not rely too much on this AI or any other technology, but the data. But the human interpretation is still very important to make use of the data. Next. And as you know, since later development, you might familiar with the integrated disease surveillance and response. So later on, we moving toward this IPSASR. And it's pioneered by WHO, and now we're talking about integrated disease surveillance. So not only one disease, but integrated now. Next. Yes, I give this is example from Timor-Leste. In the recent years, Minister of Health with the support of WHO start to integrated surveillance on TB, HIV, and malaria in one system they call ICBS-TL. So integrated mainly. So it's basically still the same, and you can still collect the data from different disease, but in order to report, you integrated them and make one form to collect in the same. So it makes its job it's easy. Next. And yes, again, this one, next slide. Next. I give example. This is about not only disease, but this is already include the human and animal. So they integrated already to human and animal side. Since we talk about One Health, and now this is a good example that in the system ICBS-DL, we already integrated because we just recently experienced the outbreak of rabies. It's now we are facing this problem now. We still can't control yet. It's still emerge infectious. So just recently we developed this and then to track to continue monitor the outbreak of rabies. Next. Yes, just continue with the slide. Yes, we call this how we report between human and animal in terms of rabies. What's reported we should gather from human, and then what's information that we should gather from animal, through veterinarian, and to work together so we can prevent further expansion severe of the outbreak of rabies in Timor-Leste. Go ahead. Next. Okay, by doing this, I think I finished with the surveillance, but I'm just quickly present about the EWAR, early warning system. Basically, it's kind of the surveillance as well. It's the surveillance that we apply to alert people about the risk or the danger that will come, and then create a system to respond to it. So by definition, what we call early warning system is the surveillance-based mechanism designed to rapidly detect signals and potential of public health threats and trigger the timely response. We don't have many experience here in Timor, but I am aware that in Indonesia and other countries, I think it's very advanced in the award system, especially for tsunami and other natural disease. But we are here in Timor, we have a very small scale of natural disaster, and the big one is a more pandemic. But we have Timor-Leste regularly facing the dengue outbreak, and which is a bit of concern for us. And yes, if you like, from the example, you can visit the e-words in the box of WHO. You can learn more about the system. I also sent some of the reference that you can read about the e-word system, early warning and response system. Next, but you have to, yes, e-words enable early detection and timely response to the health threat, preventing outbreak from escalating globally. So if you imagine the early start of the COVID-19 pandemic, which in Wuhan, China, I think you might revisit again how they start alert all of us globally about the danger of the COVID-19, and later on become a pandemic, and then give all of us a headache, and then many of people died, and many of health system were stretched at the time. COVID-19 is one of the examples that we must always learn and reflect and try to improve our system, in order to prevent this kind of a pandemic to happen again. Next, I think I should go my time. Yes, I think this is the slide, the more important slide for the early warning system. It's composed of 4 key elements. One is risk knowledge. You have to establish the system that systematically collect the data to identify the risk, make a risk assessment. And then when you understand the risk, you have to be able that your system is communicated quickly to people. So they not to take action, but they can move quickly. Just example, they take action quick, no need the government, but people. So you have to focus on this. And the third, you monitoring the danger. I live in briefly live in Northern Territory, Darwin, Australia, which is now I work serve there. Every year we always have warning about the cyclone. So if they have a very good early warning system that alert everyone when you can move, when you can stay, when you should stop going to work, so something like that, and I need to be respond. And the last one is the capability of response. So once we have 1, 2, 3 monitoring, and if there is danger and then we make sure that the country or your facilities or your municipalities or kabupaten or kecamatan or even your place at least has a capability to respond, mobilizing people and giving protection. So actually, that's the main component of the early warning and alert system. I think many countries has established the system, but we just need to improve every time. Next. Okay, this is another example. We use in Timor-Leste. Before really COVID-19 arrived in Timor, we've been prepared, we've been alert, we create the system, as you saw in this graph, and how we continue. Even though when the first case arrived in one of municipality in Maliana, we use the system to alert other municipalities until whole country got COVID cases, but we able to minimize the impact. We minimize the deaths, and we able to treat many of diseases because of after 1 year, I think we have a time to prepare all of this, learning from experience from other countries. So that's the luck of Timor-Leste. The next. Yes. Now, since I'm not allowed to talk about One Health approach quadripart, but I'm just this slide just to inform you that in order to take in One Health, we need more integrated and approach for One Health. And I think by this, it's all about One Health. Again, this we apply to the One Health awards. You can say data source integration and others. Next, this just for your information. Next slide. Yes. Since we're talking about One Health, the sector of health, human health surveillance, animal health surveillance, and environmental health surveillance, we have to integrate it in e-words platforms. So far, we still struggle globally to develop one integrated health surveillance, One Health surveillance system. And I sent you one article about HSS, One Health Surveillance System. There are 6 steps, and I hope that you can read. You divide your group by 6, and then each group, assigned to 1 steps. Read it and then discuss and interpret and share with your colleagues, and then what you're thinking, and then hopefully after this cohort of One Health participant could develop integrated One Health approach, One Health surveillance approach for us. Next. Yes, I think I have explained this. You can read in this article again. Next. The same. So many of organization is working in there, collaboration role and synergy. You can read it, just read it. My talk is focused more on surveillance. And next. Okay, this one is I take example from Indonesian system. I quote from a book, Public Health Surveillance, written by many of the medical doctors, member of BRIN. I mentioned in early slide presentation. So I send also this book, very simple and free, but I enjoy to read it. It's very simple, and then many of the example is from Indonesia, and then you can learn as such a big country, but they have a very good surveillance system. Next. Early warning alert. So this is again the example from the book. The template for collection data is there, and then how the data is analyzed. So all of there, you can just read the book again. Next. Okay, this is I think it's not really clear, but the challenge that for future direction. Key challenge of surveillance everywhere is underreporting, data quality issues, fragmented system, and limited workforce and funding. I think in Timor, this is very familiar with Timor-Leste, and I think in other countries as well. Ethical consideration that we must carefully is about data privacy and confidentiality, use of personal health information, and equity and access. So this is its ongoing problem, and it's related to the law. If you're talking about the privacy and confidentiality, we make sure that we have legal regulation or legal based system to support. Future direction, I think, yes, we should integrate the digital surveillance. We have a very advanced AI now, and hopefully we can advance more in genomic surveillance to help us in the fight. So by concluding this, as I said, surveillance is one of the it's already all science. It started in London by John Snow, and then every year, every time, you can see the evolution of the public health surveillance from simple and manual collection of data. We include in digital tools. We have computers, and you have AI now, but before that we have involved with serology and then genomic surveillance. And so all of this is very complex, but the conclusion, if you want to start with surveillance, just think it's simple. Surveillance is very simple. You can do it manually as well. Just collect, establish the system, the continuous collection of the data, continuous analysis, continuous interpretation, and quickly take action based on this data. So basically, it's research from the university. By doing this, I think I should conclude my talk. Hopefully, I'm not taking too much time, but thank you very much. Again, sorry for this internet connection and everything. This slide is we talking Dr. Darwin and Billy. Thank you very much.
Professor Nelson from Timor-Leste. So it's time for us to have a Q&A sessions. Anyone, you can have raised your hand and mention your your questions. Okay, please. Yeah. Any micro?
Thank you, Professor Nelson, and everyone. Good afternoon. My name is Ahmad Solihin. I'm from Jakarta. I have question about TB surveillance. In Indonesia, we know that TB case report on system named SITB or System Information Tuberculosis from health facility based on passive or active surveillance to detect TB by symptoms or molecular confirmation. But Professor Nelson's, we know that we know that there are TB infection, or we call TB latent. We cannot detect this kind of TB by symptoms or molecular like TCM or PCR. Yeah. The question is, what is it? In your opinion, Professor, is important to doing surveillance the TB infection in Indonesia or in Timor Leste? Thank you.
I think I should just answer. If I'm not wrong, should I answer now or?
You can answer. Yes, please.
Okay, sorry, I missed your name, sir, but it's very important question. If I'm not wrong, your question is about whether we need to apply surveillance to detect the latent TB. Is it right? Yes, TB is. I spent most of my time in TB program. I graduated in Indonesia in 1995. So my first patient I encountered is actually tuberculosis, and then my PhD is in tuberculosis. We learn a lot about TB, but recently the symptom is changed. I remember that. And TB, I don't know what happened, but the mycobacterium is also changed a little bit. We just finished this national TB prevalence in Timor Leste. 20% of the cases actually is without symptom, asymptomatic. It means that we lose even the simple surveillance, passive surveillance can detect. And yes, nowadays, like in Australia and other countries in Europe, they use more genomic surveillance for detect the latent TB. So I think as the question is, so that's why in my last slide I mentioned that we better move beyond normal surveillance now because many cases are symptomatic. But in fact, many of the TB cases that emerge in developed country through the immigrant actually latent TB. When you are young, you tend to immigrate to other countries. You live there for quite a long, and then later on it's very difficult to get this. But the country like Australia, I was in Portugal last time, and I'm talking about this. Actually most of the TB cases is latent TB. It's re-emerged because of the immune system is reduced due to the elderly or any other cases, and then come. But now they have very advanced. If I graduated in 2007 PhD in tuberculosis, I just went back, and now they're moving from simple microscopic detection and PCR to already genomic genomic surveillance DNA, and then they can detect very easily. And they actively. So you only apply genomic for the active surveillance, not the passive. So that's what I mean. So, but it needs a lot of resources, finance. Even the Timor Leste, currently we can't do genomic in Timor Leste. We still send our sample to Melbourne to Australia, very expensive in the capacity. But yes, the lesson here is, the sign or symptom of TB is changes. We tend to to detect more asymptomatic cases. Latent TB is become an issue. Now, even the treatment is, the approach is different now. In Timor-Leste, we apply if active case finding, and once we identify one member of the household got TB, we do IPT, we provide TPD, therapeutic preventive therapy to all the household. So this is the way we do, and then very simple because we don't have enough money to go to the genomic. But this is the way we approach. I think the other lesson that many of TB patients actually, based on our surveillance, they are not coming to clinic. They stay out in the community. So with the current passive approach, we can really resolve TB. We have to be active, go down to the community, first we do a step, symptom surveillance, symptom detection, and then go early, do a PCR is still good. You can still screen. But for the latent, I think I agree with you. We go more to the latent or to the genomic, and then we can detect. Thank you very much.
Thank you, Professor Nelson. That's the answer fits your questions, yeah? Okay, another questions from this side?
Good afternoon. Thank you so much, Professor Nelson. It was such a thought-provoking session. So my name is Mohammad Arif, and I'm from Pakistan. And I'm doing my master's in public policy and administration in UGM. And my question is about the animal health surveillance. Actually, in Pakistan, every year, because there are so many dogs in Pakistan, and every year there are like 1 million cases of the dog bites in Pakistan, and almost according to data, 1,000 to 5,000 people die because of the dog bites every year in Pakistan. So what does government does? It just kills the dogs, or in one of province that I live, what the strategy the provincial government has adopted, it just like it's a funny like it castrate the male dogs only and leave the female dogs, so the population does not increase. And even though this is the problem and it's a funny way, but yeah, what do you suggest that what is the best practice that maybe your country, or I don't even find any dogs in Indonesia, maybe you have experienced that, how does they have control the dog population, or solve this problem of the rabies? Thank you so much.
Yes, very good question, Akal. I think I can share with your concern about the Pakistan. Once Timor-Leste has a lot of dog. Dog is for Timor is a friend. It's friend for going to do like do hunting or something like that. So it's like a close animal that they help in, a helper as well. So in Timor, what we call aswang, it means the protector of the owner. So, but recently when the rabies come, government, I don't know, somehow, and one of the local municipality issued the instruction to kill the dogs, and then it's become be trigger national-wide protested from all of the people, and they stop. But I think yes, now we just established the surveillance. The dog bites is everywhere. Like before the rabies come, dogs bite, it's happened everywhere. Like especially for those they try to protect the owner or something like that. And since then, our approach is different. Our veterinarian, which is they are very active. So they are the leading actors in this. They force the government and they do socialization, and then within very short time, they able to vaccinate all of the dogs. So immunization is the best. You can kill, but you have to immunize all the dogs, and then it's able to reduce. And the dog bite is normal, but and then they check when you got the bite, and then now they are able to like mapping in which municipalities actually the rabies exist. Once they see, as I said, they also look at the symptoms. When the rabies affected the dog, the symptom will be changed, right? And then normally they understand about this. And if the dog is sick, they get the dog and then kill because of already infected. But they have to make sure to be infected, and then they test the how to call the sample if positive, and then they start to this area is being how to call located as an area that need intervention. And sorry, I can see you. And then give immunization. So I think the best approach is you can't kill the dog, just kill them, because it's against the right of the animals as well. But you can make sure that the dog, cat, or monkeys that you have animal, you need to give vaccination, immunization to them to protect they get infected. And then the human, once if you identify, you located that in area is already positive, that there is a dog or a little positive rabies, make sure that you receive minimal 3 times immunization to protect you. You don't need like you don't need immune rats, immunoglobulin, rabies immunoglobulin. But once you bite by the doctors already analyze you. Once you bite by the dog, and then the doctor will assess that whether you already received 3 times immunization vaccine. If you have 3, and then you just need another 2 vaccination or 3, and then to protect you. So you'll be all right. But without vaccination, the fatality is 100%. Once you got rabies, 100% you can't protect them anymore. Yeah, so I think I can share you, my main message is don't kill the dog, give vaccination, and educate all your people, and then your friends that, if you wanna have a dog, make sure that you humanize anti-rabies. That's the best way. I hope this answers your question, sir.
Professor Nelson, one more question from the audience. So you.
Thank you for the opportunity and also the explanation, Professor Nelson. I wanna ask, like, in your opinion, for public health surveillance, what's the best period, like when you collect the data? Like the data is collected manually, right? Like, is it per day or per month? When we want to get the data from the health facility that once, and also you mentioned in the ICBS Timor Leste you collect the data manually. Is there any better option than collect data manually, in your opinion? Yeah, that's my question. Thank you.
Yes, I think like when you do, depends on what type of surveillance you're talking about. Like if you do passive, and then your system is established there is for simple. Like in any health system, there is always passive health surveillance everywhere. Every health, even you work in the health posyandu, or even the health post or puskesmas pembantu, your job is to collect every diagnosis, every data patient is regularly collected. It's routine every day. But the question is, when you analyze this and then make it clear. So it's like, I think this is the weaknesses of many of the system. We collect a lot of data and then send to the epidemiologists, but many of the epidemiologists not make this data to become information yet. I think that Timor still have a problem. Most of the data collected in village, very remote area, and the data is collected manually. But now, due to the previously manually, because we don't have a quick internet speed yet compared to Indonesian, but probably have a good internet speed. But now the internet is getting better. Like every time you collect data, you can send directly to the at least district, kabupaten. Probably you can send quickly there, and then the epidemiologists and the team there can quick analyze. But it's not happened actually. Once if the data, but I agree that I believe that the epidemiology suddenly the number of the dengue cases increasing, unusual. And then it's alert one municipal. So we experience this very quick alert, and the measles sometimes it's increasing cases. So when the cases increase in annual, it's not quick like once increasing in all municipality or all places now. Some in one health post suddenly it's increased. One the increase, and then as a we do. And now we are moving to more electronic data collection, no longer manual. But still, you still need manual. You need, I mean, the data still need collected manually because need to enter by human anyway. But during the analysis and in analysis of the data, you can use tools and then computer. A simple program like Stata or R. You can do. Even the AI are very good now in detecting, but don't trust yet. You need still the human trained epidemiology to see the trend and then alert the community. This is very important because if you false alert the minister or government official, you'll be in trouble. Because it's involving resources. You have to mobilize a lot. Divert the data that you collect. So I hope this answers your question. Thank
Thank you, Professor Nelson. We still have 4 questions, 2 from this room and 2 from online platform. So because it's very interesting topics, so for this time, I would like to give a chance to this.
Thank you. Good afternoon, everyone. Dr. Professor, thank you for the presentation. My name is Henry. I am from Papua New Guinea, a country of diverse as well, with 10 million people. And my question is basically in terms of malaria, because I've been working as a program coordinator with malaria in the country, in one of my provinces in Papua New Guinea. But I am so, from the data I've seen, Timor-Leste was certified free from malaria on the 24th of July 2025, just recently. So
yes.
Like 90% of malaria cases in the Western Pacific comes from PNG. PNG is the high burden country, especially in terms of malaria. But in terms of surveillance in this part of being free or certified free from malaria, what is your in a nutshell, how would you give me or the audience explanation of how did you go about in terms of surveillance for malaria? Thank you.
Yes, thank you for your question, my colleagues from Irian Jaya. Oh, Papua New Guinea, Irian Jaya.
Papua New Guinea, PNG, yeah.
Yes, I think we learn from you as well. I'll just give you an example. I was, when in 2004 to 2007, I did my PhD in Darwin. So more my colleagues, Professor Nick Anstey and Rick Price, the best professor, the renowned professor of malaria, just one they work in the Irian Jaya, and then they also work in some visit Papua New Guinea, and then from there we learn a lot about this. We haven't done research in Timor about malaria, but I did at TB. And then from there, I learned that actually chloroquine resistance is very high. And all the drug that we use to treat malaria at that time is a little resistant, but we haven't changed. And the new drug is just coming, quartum. And when I returned to Timor, my fellow Minister of Health, he he tried to introduce a new drug, Wartem, to treat. Because if the study in PNG and malaria show the chloroquine is resistant, why we should keep chloroquine to treat malaria? So it changed. And then when I came to ministry in 2007, I just continue with the WHO with the Global Fund. We continue use cotton. We recall all the anti-malaria drug that with resistant. They started to conduct in PNG and in the surrounding area, including Irian Jaya. And you know, when I came to the office, we have malaria cases 200,000 per year. And then before I left the office, it's down to 6,000 per year because of this. And then was lucky that at the time, the new diagnosis tool, it's coming, called RDT, Rapid Diagnosis Test for Malaria, just right. It's very early in my tenure as a minister. I was lucky at the time. So just quickly introduced. So my suggestion is quickly adopt the technology and then use research to inform your policy. So if you think there's a resistance there and then your studies found there, you know that the AMR is one of the surveillance. They continue to do drug surveillance to see the resistance. One of my areas is AMR, antimicrobial resistant. But now we face TB is resistant, drug resistant TB is everywhere. Even like in the hospital, you really face a lot of drug resistant TB, but we still use it. So it's very dangerous, and then most of the disease will come back. You can't treat them long. So, and we conduct the routine surveillance. We adopt the new technology, and you know it's long time until 2005. We have a certified that receive certification to treat malaria. But you know it's combination of things, and then we also invest a lot in vector control. It's very huge. Our team went down to every places that you know. They also make a surveillance to the population of the mosquito. If the mosquito is increasing, the population is increasing, and then they start to do the intervention as well. So this combination of all different intervention from environmental through the drugs and then through this new technology adoption, we're able to do this. But for now on, we still do cell surveillance, and then we do genomic to continue monitor whether there emerge of the malaria. We have like imported cases from Nusa Tenggara Timur, but it's imported, and then once they we detected, we quickly treat them with the. Now we have our microbiology is improving a little bit. We can see whether use the sensitive anti-malaria to treat quickly the disease. So I think from you, my friends, I think you can use this. Make sure that you adopt the proper technology. Continue to routine surveillance to see the cases, combine with vector control, and early detect people with the parasite inside the blood and then treat them. If now we still have anopheles here, but we don't have parasite any longer. So you can't really get rid of the mosquito, but you can get rid of the parasite. So that's the, we have a problem in dengue. I can give example now. We work with the UGM as well to introduce Olbachia to prevent its biological control and then to prevent dengue. So the similar approach. I hope this answers your question.
Very much, Professor Nelson.
Thank you.
Okay, one more question from this room, and then we can move to online platform. So.
Thank you, Professor Nelson. My name is Risna. I'm from the International Health Problem, and I have a question regarding the the integrated surveillance, the way you said before. And Indonesia, we have a lot of digital platform for reporting and recording system for that. And sadly, it's not integrated yet. So the healthcare staff need to work a lot and inputting a lot of same data again and again into a platform for patients' data. And do you think the integration of all of this platform will help them to reduce their burden in inputting the data, or will it be like the same? Because at the end, the people need to input the data from different diseases. Thank you.
I missed the last one, just internet connection. So the last sentence.
Maybe do you think integrating all of the system health reporting system will help the healthcare staff to reduce their burden of inputting the data for monitoring and evaluation? Thank you.
Of the surveillance and the health system itself, like every country try to move toward integration. So I actually train in transdisciplinary methodology. My PhD is transdisciplinary. We don't talk about discipline, interdiscipline, multi, but trans. It means that in one body or in one approach, in one strategy, must has capacity to comprehend the disease, the health problems, and then provide comprehensive solution. So one of the areas the integration, but we have to be careful how to integrate it. This should be context specific problem. But for One Health, yes, I agree that it's time for One Health is we all know in our medical school, we understand about the diseases sometimes come from human and environment, but One Health is just emerged recently. And then it's kind of progress. So we have to build integrated approach for the One Health. But if I challenge you to read the article One Health health system, read through it, and then you will see the sixth step. The sixth step will answer to your question, whether it's visible or not. I'm not in the position to say, but I believe not only me, but WHO and all experts, they say that it's good way. And I can see like from the malaria and HIV and TB in Timor-Leste is worked, but two others I haven't. But I suggest to include more diabetes because many of TB is diabetes as well, included there. But this is very important. Like why TB and HIV is important? Because the drug is quite similar. Some use rifamycin. So this is good. But to others it's far away. It makes you be careful. So as a researcher, penalty, your mind always thinking, ask question whether it's right or not, and then continue try, continue test, and then find the new way. So I think that the only I can answer. But for the One Health, I challenge you to read the article that I sent to you, and then read the sixth step, and you will understand whether it's easy or not, and then whether One Health we can develop one integrated health surveillance for One Health. I hope this answers it. Thank you.
Okay, thank you once again. And then we move to online platform, to the Zoom. There are two questions. Okay, Professor Nelson, the first questions come from Joseph Dargantes from Philippines. Thank you, Professor, for a very informative lecture. I'm Joseph Dargantes, a veterinarian from the Philippines. I'm currently working with One Health rabies program in hands with a digital surveillance system. May I ask the following questions? The first is, what is the best approach for evaluating a disease surveillance system and which indicators should be prioritized? The second, in resource-limited settings, which surveillance system attributes should be prioritized during evaluations to maximize public health impact? And the last one is for disease such as rabies that require multi-sectoral collaborations, what indicators best reflect the effectiveness of surveillance system in supporting disease elimination goals?
Yes, I think this is very good question. And when you're talking about, I think I can give an answer. Like when we talk about surveillance, we talk about the system. It really depends on the what they call the country or local based situation. I can imagine where you stayed now, but I can give you an example from Timor-Leste. At the early, we have established because we have a problem of internet connection. In my time, I was minister, even no computer at the health facility. So, but we have to establish surveillance in every health facilities. So the system we built, we create the form, the data collection form. So surveillance is composed of data collection, data analysis, interpretation, and dissemination of the result, and then making action. So if you look at you go back to the definition, you can track every step, whether your facility is able to collect the good quality of data, given the fact that good surveillance system I mentioned before, you have to be simple, flexible, and we're talking about validity and the others. Make sure that you check all of this. If the data, if the collected is fulfill all these components, it means that your system is good, but you need to evaluate every time. And then just do, that's what we call about evaluation, and look whether your data is being collected right, because sometimes people change, the new, the competent health workers will replace and they move into other place and the new one coming, whether your system is still working there. We call talking about the stable or not. So that's all about. And the second, you're talking about what is the best approach for what is the indicators. So from these, I think the indicators we should focus on this. I mean the system again. Focus on the data collection, whether the data analysis is representative, valid or not, and then the data dissemination is very quick or not, whether the place, and then whether the action is being taken quick. I think by doing this. So every step, make sure you have to check every time it's working or not. And then by doing this, like every time we say that the manual data collection is not, and then we keep improving every year. We train in national, and then people is not working, and then we go down to the municipal level, and then bring more epidemiology. And then we don't have epidemiology, train more, epidemiologists to send there to train. So indicators, I say that it's you can develop, but make sure that the based on the real definition of the surveillance. I mean the context of Timor-Leste. And for resources limited country, I just give example. We still we use we got support from WHO. Timor-Leste is a very limited, one of the example of limited resource limited country. We don't have enough epidemiologists to work in every health facilities. Even in the municipal, it's very hard to have a competent epidemiology. We only have 4 or 3 in the countries. It's about a human resource wise. And technology, we are very low. We have a very problem with internet connection. But there is a technology that I use, like now the system developed at WHO. You can import what they call record data without internet, and then very quick and send things like that. So the conclusion is our surveillance is Timor is not great, but we still keep the principle of the surveillance to alert us. So far, with this very, I'm not saying very rudimentary surveillance system in Timor, but we were able to detect a measure of the outbreak. Dengue is, we continue monitor, diarrhea, and measles, malaria is gone, but the leprosy that we eliminated and then it's coming back. So this is the trend is we are going to monitor. For diseases, rabies require multi. Yes, as I said that we are in the current of outbreak of rabies. It's not yet end. And then this is our first experience that working collaboratively with other sectors. But after we are able to manage to tackle these, reduce the transmission of dengue, we just realized that the role of veterinarian is very important in this area. And then now we are open more, like through Menzies, we support veterinarian to establish a very good microbiology lab to continue work and then support them. And then even develop online surveillance system to them to work. So I think that's the only thing that I can say to you. For the One Health approach is become stronger in Timor-Leste. We have together write the national Minister of Health, Minister of Agriculture, and other sectors lead collaboration in this area. But more often, the collaboration is only happening in the higher level. So what I want to see, or probably you agree with me, is more in the lower level in the implementation. We're talking about more in the municipal or sub-municipal level, sub-district level. We need this to be more level areas, which is not really recommended. We want this to go down to the community level. I hope this answers you, but you can still read. I said I sent a number of reference there about One Health surveillance. One case is surveillance in chicken in Bogor, which is even influence there, and it's a good example you can read. And Ebola in Africa, one of the examples that you can read as well to enhance your knowledge about One Health surveillance. Hope this answers you.
Okay, thank you very much. We do appreciate for your kind answer and also for your valuable talk. I do apologize because due to the limitation of time, so the session should be stopped. Thank you once again, Professor Nelson, and we wish you have a very enjoyable evening together with your family. Yeah. Give applause to Professor Nelson. Okay, the next speaker has already joined. Okay. Hello, Ahmed. Good morning, Ahmed. We still need to wait. Ahmed?
No, you don't need to wait. Now everything is good?
Oh, okay, that's good. So next session will be about the evolutionary of pathogens emergence that will be delivered by one of the experts from Leipzig University, Germany, Dr. Ahmed Abdul Wahid. Should I read his resume? Okay. Dr. Abdul Wahid is head of the laboratory Institute of Animal Hygiene and Veterinary Public Health, Leipzig University, Germany. He's also a member of the WHO Strategic and Technical Advisory Board on Neglected Tropical Disease and several international scientific societies, including DTG, Evangelist, if I'm not wrong, STMH, and co-founder of the Network of Young Researchers in Medical Infectious Disease, Networks Young Infections Medicine, developer of a mobile suitcase laboratory for rapid detection of viruses, bacteria, and parasites deployed in multiple African and Asian countries. So please join me welcoming Ahmed to this session. Ahmed, time is yours.
Yeah, thank you, Dr. Abdurrahman, for this very kind introduction. And for all of you, which know that me and Dr. Abdurrahman, we are close friends. We are working together, I think, for almost 10 years now. And this is really a great adventure both together. So do you see my screen in full, or you don't see my screen? Yes, okay. I think you can see my screen. That's really great. So I would like I think there is many speaker and speaker in a many direction, but I will try to really fix some definition together, because if we'd like to start speaking about, because the whole summer course is about emerging disease. And in order to keep some definition really very clear, is that we need to start with this. Despite we speak about emerging disease and infectious diseases, but we need to keep in mind something very important, that despite COVID, you see COVID is down there, it's take a life of around 17 million people. But if you compare it to the other outbreak we lived in our world, it's the most shortest and the lower death rate of all outbreaks. You see, for example, we have a Black Death outbreak which lasts for 50 years. Can you imagine nowadays we suffer 2 years or maximum 3 years for COVID outbreak, can you imagine that you live a few hundred years back and you have an outbreak for 50 years? We have an outbreak which lasts 100 years. 100 years. That's, you can imagine how big is this outbreak. That means, despite COVID was really devastating for all of us, still you can see it's shortest. Why? You can ask yourself why. Because very simple, we have developed tons of vaccine, diagnostics, and treatment which can be easily used. Some people said, oh yeah, maybe the people already created this before the outbreak. No, we just have a lot of knowledge which led us to create these vaccines. So I think you have heard this, but I would like to keep in mind that what is emerging disease? Ask yourself, what is emerging disease? The emerging disease, they have different definition. For example, if the pathogen is known but come in a new geographical area, it's an emerging disease. That means it must not be that we said, okay, it's completely new pathogen. No, it can be a known pathogen but come in a new area. Also, emerging infectious disease sometimes associated with heterogenic modality. That meant that sometimes, if you remember, we have this liver transplantation and organ transplantation has started a lot. And by doing organ transplantation, we have discovered that we are transferring, for example, hepatitis E virus. So this is an emerging disease because it's happened also by this. Also, if I have a known pathogen, but a new biological phenotype, for example, influenza virus, it's known, but all of a sudden we have a mutation. It's become a new virus. Then this is an emerging disease. We have also, and this is everybody think, novel infectious pathogen. For example, COVID for us was completely novel pathogen. For that, this is an emerging disease. And also, sometimes we have a disease, but we don't know the etiology. For example, Alzheimer's disease, it's a memory loss and so on. It's a disease, but anybody know the cause? No, nobody know the cause. So that's mean if you keep emerging disease, please keep it open. It's not always a novel infectious disease. It can be any other thing than infectious diseases. If you see this map, and I think you saw this map a lot. From 2003, we are facing tons of emerging disease. And recently, we are hearing about hantavirus. It's not a new one, but we heard about it. We heard about the Ebola virus in Africa. Yeah, but you see a lot of emerging disease happening everywhere and worldwide. But what about Asia? If you focus about Asia, and if you focus about Asia, you see the timeline is different because it's not like in Africa, we heard about Ebola virus, we heard about monkeypox virus or mpox virus, we heard about some disease, but here the situation is different. We hear a lot about avian influenza, we hear a lot about Nipah virus, we hear a lot about mosquito-borne viruses. So what I would like to see is that, to say here in that in Africa, you have more direct contact like Ebola virus, like mpox virus. In Asia, we have more respiratory-borne diseases and vector-borne diseases in some area like dengue, chikungunya, and Zika virus. And of course, recently, Nipah created a lot of alarm, especially coming started in Malaysia, Bangladesh, India, and so on. For that, it's really is not easy to go, but at least we know that the emerging disease, if you see the whole world, is different from the emerging disease in Asia, and for that you need to be sure. Of course, if we ask ourselves, the largest emerging disease coming out of Asia, like COVID, why? It's very simple, because the population is huge. If you see that how many people live per square meter, you see that in Asia the number of emerging diseases or number of expansion or number of transmission is very high because of this emerging because of the condensed population in this area, because of that respiratory disease, vector-borne disease, and transmit very fast and spread very rapidly. because of the population density in this area. In Africa, the situation different, because in Africa, if you'd like, I don't know if I saw some friends from Uganda and so on. The distance is huge. You can move hours without finding any people, because Africa continent is very huge and is not like dense like in Asia population. And we always forget that. And this is very important. We always forget that emerging disease is something, but endemic disease is even more important. As you see, lower respiratory tract infection, tuberculosis, and diarrheal disease, they are more leading for disease burden in Asia than other emerging disease. That's mean, and this is what's happened, for example, when we dealt with Ebola outbreak in Africa, the people died from malaria more than people died from Ebola viruses. People was infected with malaria than people was infected with Ebola virus. During COVID outbreak, we have more cases of dengue fever virus than COVID itself. That means sometimes if you are dealing with emerging disease, keep in mind that emerging disease is not the main problem happening. The media focusing on that, the country is focusing on that, the politician is focusing on that, but the real problem is other endemic disease happening in the country, and we need to keep this in mind. The other issue when we speak about emerging disease, because sometimes the people said, okay, emerging disease is only emerging, is only dengue is happening alone, COVID is happening alone. No, we usually see, and this graph show you, an over dual infection or sometimes triple infection. You see sometimes you have Nipah virus and you have other disease like influenza or co-infection. Sometimes you have dengue, chikungunya complex or chikungunya Zika complex. That's mean when you do diagnostic and you do surveillance, you need to keep in mind that actually dual infection is really high. And for that, you cannot say, I will diagnose only COVID, but I will not diagnose anything else. So what is the factor leading for emergency or emerging for new disease? Please, I know you may heard this before, but it's better to keep you the point. I tell you what's emerging disease, why we need to keep in mind in emerging versus endemic disease, like the people speak about rabies problem a minute ago. But now I will take you why we see new diseases. We are ease of travel. You know, Abdurrahman can come to Leipzig to us in less than 15 hours. That means if he started with influenza virus in Indonesia, he transmitted the virus in less than 15 hours to Germany. If in Germany he got some infection and returned back to Indonesia, then this is less than 15 hours you get the infected. That means ease of travel make really it very easy that the infection travel long distance without any problem. We are expanded population. We was until the beginning of last century, we was around 2 billion. Now we are close to 9 billion people living on this earth, very close to each other. And this is also lead to increase of some disease. Not only because of our population, you need to also make food. You need to make intensive agriculture, like poultry, like chicken, like cattle, like pork, whatever. This increase of number of animals, increase of intense agriculture, all of that create, because you need to create food for these people, and creating food, you see a lot of diseases coming and jumping back and forth. We have changed the ecosystem a lot. You see this island, if you see this island 600-700 years ago, it was a green, very nice island, but now it's New York, full of building everywhere. That means changing in the ecosystem, that we remove the forest, we remove the green area and build a lot of building everywhere, even also in the desert, because desert is also an closed ecosystem. You think desert is okay, it's a very nice yellow area, it's free, everybody can do it. No, it's a closed ecosystem and has own ecosystem and has own important in the mother earth. For that, changing the ecosystem create a big problem. Climate change, we face this a lot. If you are living in Germany or in Europe in the last few years, you will feel this less cold months, low ice, or very extreme weather with very extreme ice. And we see so temperature in Europe, 35, 40 degree, 35, 40 degree. Was not the case before. So this means climate change is happening. Climate change can affect. We see, for example, in the last 2 years, we start to detect Aedes aegypti here in Europe. We start to see dengue. We start to see chikungunya cases. In Europe, this was not there. We recently detect malaria in Romania. That means disease spreading because of climate change and lead to a very important issue. Microbial evolution. Please keep in mind that the microbe, like antimicrobial resistance, the bacteria which resist the antibiotic, the viruses which mutate. You remember in COVID, Omicron, Delta, whatever, they are the pathogen will not stay and wait for you. They will really do a lot of mutations, and this evolution lead to the emerging of new disease. Also, as a human being, we are very talented in coming nearby pathogen. We are very talented. For example, air conditioning. In Jakarta now, we are sitting in a very nice room with close the window, a very nice air condition, and you are spreading the virus among yourselves. If you are coming here to Germany in the cold months, we are turning on the heating system very hot, that we are living in tropical country inside our homes. For that, air conditioning is good, but sometimes it creates massive problems. Also, transportation of goods, transportation of livestock, social changes, deforestation, uncontrolled urbanization, daycare center, the kindergarten, and so on. This is, if you have children, I think all of you now young, but the people has children, they feel this. Every 2 weeks, their children are ill, they have respiratory infection, they have this infection, they have this infection, because kindergarten is like a place of the amplification of viruses and bacteria and so on, because it's like a big cell culture room where the children can transmit the infection to each other. Also, a big problem is war. War and political instability can create a lot of problem. We know that the problem in Gaza, transmission of some enteric diseases, war in Syria, polio virus was emerged again after the country controlled the polio virus infection in Syria. In Sudan, we see a lot of problem with dengue virus, cholera. This disease was under control when the government was stable because of the war. This one, even currently the Ebola outbreak. The Ebola outbreak happened in East DRC, East Congo, eastern part. They have now like a kind of civil war in this area where the people fighting each other. And it's not easy to control outbreaks if you have fight, if you have war, if you have some problem. It creates some diseases and it's lead to diseases. For that, we hope that the situation will be stable everywhere. But keep in mind, when war started, you ask which disease will appear, because this is always appear like this. And for that, you see, I take you what is emerging disease. I take you which factor lead to emerging disease. And for that, the world have said that we need to prepare ourselves for pandemic preparedness. You will hear this word a lot and a lot. And please keep in mind, everyone, that pandemic preparedness is not like wait until an outbreak is happening. No, it's not like this. It's not waiting until something is happening. It is a proactive effort, multidisciplinary, that many people working together in order to stop an outbreak before happening. For that, keep in mind this very important issue. Disease outbreak or pandemic preparedness is not waiting for an outbreak to happen. It's a proactive effort, multidisciplinary, in order to be sure to stop an outbreak before it happens. And for that, we have what's called the health security cycle. What a health security cycle? It's very important to keep this in mind. Health security cycle, it's called prevent, detect, and respond. What I mean by that? I mean that try to prevent disease from happening. For example, in the farm level, this is one health. In the farm level, do biosecurity. Make a very strong vaccination program. Be sure to minimize contact between human and wildlife. Try to stop antimicrobial resistance from spreading. And this is to prevent. When it's detected, and the previous speaker we spoke about the surveillance, and the whole course is about surveillance and how to do a surveillance, human, animal, and environment. This is very important. You need to be sure to identify very rapidly any pathogen in order to be sure once you identify, you can make the response. So rapid identification and surveillance tool, it's the second part that detect. The last part is a respond. If you see an outbreak, then you need to respond very fast. You need to react very fast in order to stop the outbreak before spreading. And this is the world is doing with the Ebola outbreak or other outbreak. That's mean you need for all the time to do prevention. You need all the time to do detection. If anything happen, you need to respond. For that, it's prevent, detect, and respond. Keep this in mind because this is very important agenda. You need to keep it in mind if you work with pandemic preparedness and emerging disease. You will hear and ask yourself now, while you are sitting, what is disease X? Ask yourself, what is disease X? Usually, disease X, and this is we put it in science, it's a hypothetical unknown disease which might trigger an outbreak in this situation. Usually, we think about zoonotic disease because this is very fast spreading. Viruses more than bacteria, usually responsible for big outbreaks. For that, disease X is something when we react, if you see the differences, if I have a known pathogen like influenza virus or an Ebola virus, I know I have a specific treatment, I have a specific diagnostics, I have a specific vaccine. In case of disease X, I need to keep the flexibility of my system. I need to be flexible to react to disease X because disease X might be a new disease, might be a known disease. For that, I need to be sure what I'm dealing with. For that, the difference between known pathogen and disease X is flexibility, how I am flexible for that. And for that, each country and each region, they have created what's called a priority pathogen list. The African Center for Disease Control, the CDC, European Center, the National NIH in the US, WHO. Each of these have created a list of pathogen which we can say it might become a big issue in the world. And as you see in Africa, for example, viral hemorrhagic fever, it's a priority list. Why? Because you see now Ebola, it's a big issue in Africa now. For that, each country or each region define what is a priority list and what is our problem or what we can control this one. And for that, in order to come together and react together, there are a lot of global initiatives. And why I'm telling you this global initiative? Because you as a young researcher, as a scientist, as a senior scientist, as a leader in the UGM or other universities, you need to know this global initiative. Because if you know this global initiative, you can create your research based on your global initiative where your country has signed agreement with many countries. The first is called WHO Hub for Pandemic and Endemic Intelligence. This is a hub developed by WHO together with the German government in Berlin. And the aim of this hub is not to detect pathogen or to use the AI and the data generated, either genome data, surveillance data, weather data, whatever data is available in the world, they put it on an AI module in order to create a model what we expect disease in the coming 10 to 50, 60, 100 years. By using this prediction model, we can expect some diseases. Some diseases, of course, can come without expectation, but we can expect diseases which can really help us to react very fast. And another initiative called the BRIT Initiative, the Preparedness and Resilience of Emerging Threat. And these said, okay, instead of we are dealing with influenza virus alone, with Ebola virus alone, with rabies alone, they have what's called the paradigm shift from individual pathogen to syndromic approach like respiratory, vector-borne, on foodborne disease. It's a good initiative, and it's based on either foodborne, respiratory, airborne, or vector-borne diseases. There is a global health security agenda has been signed by more than 70 countries, and Indonesia has signed this in order to react with zoonotic diseases and make this as a priority list and try to fight them within the countries. There is another initiative, and this is the blueprint of epidemics. It's called Collaborative Open Research Consortia, and these people come and said, okay, we are dealing with influenza alone virus, with Ebola virus alone. No, we cannot deal with this. We need to create another way of a strategy of work. We call it family-based strategy. Family-based strategy means that instead of I'm working with SARS coronavirus or instead MERS coronavirus, I work with the coronavirus as a family. And instead of working with Ebola virus individually, Ebola, Sudan, Bugodugu virus, and so on, I work with Filioviride. Or instead of working with West Nile, dengue alone, yellow fever alone, and so on, I work with a Flaviviride. And I work like this. I make what's called a prototype. A prototype means I develop a prototype vaccine, a prototype diagnostic, a prototype medicament, which can be what's called switch. All of a sudden, I can really switch this prototype to be specific for the current outbreak. And this is what's happening for the Ebola virus right now. They don't have, for Bugodugu virus, we don't have a vaccine, but they are trying the information we know from the Ebola Zaire virus in order to create a new vaccine for the Bugodugu virus. And this is what's called the switch mechanism. I have a prototype, and by having a prototype, I can easily and very, very fast make a vaccine or diagnostics or whatever. And for that, you will hear a lot in the coming days if you are following the Ebola outbreak happening, the 100-day mission. 100-day mission. What I mean by 100-day mission? As you see here, when COVID, until we have effective vaccine and effective treatment and effective something, it took us almost 6 months up to 1 year, 1.5 years. But the aim of this 100 mission, which developed by CB, as you see from the top right, it is within 100 days, we need to have a vaccine ready, which this vaccine can be implemented in the outbreak, diagnostic ready, and also treatment ready if available. And by this, they have created what's called library of vaccine prototype. For example, how I can make a prototype for a specific vaccine for a specific family, as I said earlier. Rapid response platform. What I mean, it's called plug and play. That means I can have like a messenger RNA-based technology or inactivation-based technology or attenuation-based technology, and I can very rapidly switch it and create a vaccine which can really globally tested and globally distributed. And this is a 100-day mission, and please follow this CB because there are many investments from many countries in this one in order to be sure to be able to stop an outbreak before spreading within 100 days. They have tried this first in Marburg virus in Rwanda, and now they are trying the same concept in the Bugodugu virus outbreak or the Ebola outbreak in Africa. Also, there is another initiative which is very important called 717 Alliance. And 717 Alliance, why it's very important? Important because it tells you within 7 days, you need to detect the suspected outbreak. Within 1 day, you need to inform the whole people that the outbreak is happening. And within 7 days, you need to react and respond. And they call it 717. Detect in 7 days maximum. You notify everyone in the same day, and try to make a very strong response within 7 days to be sure to stop the outbreak before happening. And this is very, very, very important. So I think I took you from the emerging diseases, what's emerging diseases, what's factor leading to emerging diseases, what's pandemic preparedness, how to prepare ourselves to pandemic preparedness, and how to really the global initiative about pandemic preparedness. From the One Health perspective and diagnostic, I will take you now to part where I'll show you a lot of our work is the global One Health challenges. And the first thing is capacity building. We have a big problem of capacity. We have a lot of diagnostics, we have a lot of digital tools, but we always think in a very complex tools to be implemented everywhere. No. What we have done is that we need something like that. We need something which merge between technology and nature motor. You know why Elon Musk is now a billionaire or trillionaire in the world? Because he is thinking out of the box. He using the sun power. He using electric car. He using instead of creating Wi-Fi on the ground, he create this Wi-Fi or Starlink from the sky. For that, you need to think out of box. Use the nature motor like sun, like horses, and mix it with technology. This is very important. We have created this what's called mobile suitcase laboratory, and it has been used also in Indonesia by Dr. Abdurrahman from UGM. And as you see, it's very simple. You have sample preparation in one suitcase, sample detection in one suitcase, using the sun power to power bank your suitcases. Sometimes if you're working with emerging disease like Ebola virus, you are implementing what's called the glove box. And in this suitcase, we have implemented novel technology. One is called SwiftX, and SwiftX, instead of I'm capturing the inhibitor, I'm capturing, in case I'll capture DNA and RNA, I'm capturing the inhibitor and leave the DNA alone. For that, I can do it in 15 minutes. And we use isothermal amplification technology called recombinase aided amplification assay, where you can amplify and detect in less than 15 minutes. So the whole time is around 1 hour. Half an hour to 1 hour. So we implemented this technology in many countries, and you see also Indonesia, we have been used it with Dr. Abdurrahman. And as you see, these are the countries where we have implemented these technologies and use it on site. I show you one example of the Ebola outbreak in Guinea. We went to local hospital. We have the suitcase and glove box and power bag. We need to prepare the room with the glove boxes and the suitcase. The people, of course, need to wear PPE, personal protection equipment. And then after that, we do sample extraction in 15 minutes. And of course, sample preparation or sample detection in 15 minutes. We have used this during the Ebola outbreak in Guinea. And as you see, with real-time PCR, we almost have the same sensitivity and specificity. And as you see, we used oral swabs. And as you see, why oral swab? Because during the outbreak, the people don't want to give you blood because they are afraid that you inject something into them. For that, we use swab. And as you see, we can detect the virus 2 days after infection and up to 13, 14 days after infection. And after that, the virus will go away or the patient will die, unfortunately, after 13 days. But you can detect it really in a very good sensitivity in the swabs, the Ebola virus. We have used this technology, and we are part of what's called Rapid Response Mobile Laboratory, where we can really deploy it everywhere in the world and test the pathogen in a very efficient way. We also implemented next generation sequencing, nanopore sequencing, which is a very small device, as you see it here. And we can really, before I go into the sequencing, this is very important. Now the WHO has created minimum standard for mobile lab, because if I told you I have a mobile lab, if this mobile lab is how I make an accreditation for it, you cannot do the normal labs. For that, the WHO has created for mobile labs an accreditation system. And for nanopore sequencing, what we have used is that, and this is very important, I would like to tell you this, we call it catch-all surveillance. What I mean by catch-all surveillance, instead of I'm testing each and every person, I am testing water, air, vector, and by this I can capture the pathogen in a big population without testing animals or human. I'm just testing slaughterhouse wastewater and wastewater, for example, here in Leipzig, We have tested the wastewater, and we can really detect which pathogen is appear in the wastewater at which point. And we call this, instead of, we call it environmental surveillance, we call it catch-all surveillance. Why catch-all? Because you implement next generation sequencing, you detect wastewater, air, or slaughterhouse water, or whatever. As a scientist, I would like really to tell you the second challenge is that you need to translate what you are doing in public health policy. You cannot just work in the lab and don't translate what you do in a policy by the public. It's not really doable. And for that, it's very important. We done this with this Adapt One Health Network in 7 sub-Saharan African country, where we are not implement only One Health concept. What we have developed here, we just show it to the public, to the policymaker, and directly implement measurement for antimicrobial resistance. The other thing we face into the One Health challenges is the collaboration. We don't collaborate with each other. As you see, the collaboration always bilateral, from India to Germany, or from Pakistan, or from Indonesia to Germany. But I'm speaking about what's called triangular collaboration. We need to collaborate together, and in order to fight outbreak and fight emerging diseases. And because of you are here, we have also another project called Prepared, where we develop with around 14 countries, we develop rapid diagnostics linked to a smartphone, where you can detect the pathogen very rapidly, very efficiently, in a very efficient way. Also, a big problem if you are dealing with outbreak, you still rely on Germany or Europe or the US to ship. Nowadays, with the Strait of Hormuz and Iran problem, you see that a small closing of a small area in the world has led to a big problem in the economy everywhere. And for that, it's very important, and this article show you, it's very important to keep a local production everywhere in the world. So it's need to keep your local production of diagnostics, of vaccine, of treatment, or medicament in your country. We have realized this, that with the first production of the suitcase in India, with a collaboration of a local partner. We also, a big challenge we are doing in our work is to involve the community. We think that scientists, we need to publish our paper, but this is wrong. Actually, as a scientist, as you see, the university has been established to serve the community, is not to serve the publication. And for that, you need to be sure that the local people can be participated in what you are doing, can be a part of what we are doing. And there is a word called citizen science, where you need to involve your people into the issue and the work you are doing. We need to have innovative teaching. I think all of you sitting in the same hall, listening to the same lecture, if you see old time, new time, the same thing, persons, everybody sitting, looking to a person who displays something, the same happening nowadays. We have done some changes in our lab, where we try to implement a new VR, and this will be really a very good part of what we are doing to implement novel teaching, and to balance between using an AI and using the human touch. We need to discuss this a lot. Also, we have created a One Health course, which is international, where we have a really more social media campaign into it and involve many stuff into it. You need to be sure when you do One Health to link it to global initiative. I told you many global initiative for pandemic preparedness. We have also sustainable development goals, where they will be re-evaluated, but you see that also it's the One Health goals, or these goals fits very good for One Health, pandemic preparedness, and emerging disease. Please keep in mind. I reached the summary here. We have challenges. We need to be sure to build capacity. We need to be sure to translate science into public health policy. We need to strengthen triangular collaboration between multiple countries. You know, the Ebola outbreak now, it's DRC, Uganda is involved, despite it didn't start, and many other countries will be suspect to be 8 African countries if this situation does not stop. So triangular collaboration is very important. Local production is very important. Involve the local community is very important. Innovative teaching is very important. Linking to global initiative is very, very, very important. Keep in mind, if you would like to react with emerging disease and do pandemic preparedness, you need to keep this cycle in your brain. You need to prevent, you need to detect, and you need to respond very fast. And these are the integrated health security cycle, which is very important if you are working with emerging diseases. Think globally, act locally. You need to act locally while or do everything locally while keeping the globe in your brain, because we are connected more than before. I really thank everybody here in this list. We are working together since many years, including Dr. Abdurrahman and Dr. Budi and Dr. Trey from UGM. And really, I'm very happy to be here and present. I'm so sorry I'm not face to face with you because we are involved in many situations now, including the Ebola outbreak. And I hope all of you the best. I would like to thank our institute, where we have a very nice team from multinational country with many people and many faces here. And I would like to ask our funder, which fund our project over the last more than 15 years now. And if you would like to contact me directly, please use this contact form or use my direct WhatsApp in this contact information, or please like our LinkedIn, where we put our recent news, training, and other stuff. Thank you very much. And Abdul, I am finished, I think, on time. Thank you.
Thank you, Ahmed. Give applause to him. Now we move to question and answer session. This must be very important and very interesting topics that may pops a lot of questions from you. So, one question from this side.
Good afternoon. My name is Hamza Abu Hlayed from Palestine, PhD student in UGM, Department of Physiology. Good afternoon, Doctor. I am very happy to meet you today. Thank you for a great presentation. I want to ask you a very important question about using AI, because we know the importance of AI and the development of AI, because nowadays we can summarize many articles and we can read, can accomplish research with short time. So I want to wondering and asking about what your perception about the using AI in discovering new vaccination and discovering new treatment for many diseases like cancers, like a chronic disease and infectious disease that there are no treatment or vaccination yet. So I think using AI, it will shortage the time in the 10 years or in the next 10 years. So I want to know your perception about using AI. Thank you, Doctor.
Of course, it's a valuable tool. It's very important. And we start using it a few years ago. But the tricky part of AI, the AI cannot generate something from zero. You cannot tell them, okay, please tell me which virus I have now, which vaccine I can do now. No, the AI, as much data as you produce, as much data you enter into the AI, as much perfect response you will get out of it. And for that, the gold now, the gold is not like the gold or the money or the oil. The gold now is data. If you have enough data, you can use AI very efficiently. Nowadays, as you see, let's say the Western world, Europe and US have realized this long time ago, and they have this kind of very good data collection. Unfortunately, in Africa and in Asia, we was in the winter sleeping time, and we didn't have enough data for what's happening on site in order to fit the AI with this stuff in order to be sure to get the right answer. For that, the AI is a valuable tool, but we need to be sure to give it the right data. And I think each government now realize this and will really work hard on that.
Okay, thank you, Ahmed. Any more questions from you? Is there any questions from the online? No? Any questions? No questions. It's very clear. Ahmed. So your
It's
talk
very
is very
clear.
clear, yeah. No questions
But,
from
but let
the
me
audience.
but let me ask them a different issue. What about let me ask them a different scenario. What is the emerging disease you have in mind, and how you as a student can really try to react to this or try to do a role in this? What do you think? Because we see a lot of people from many countries here. It's not only we have Nepal, we have Indonesia, of course. I saw Uganda, and I saw Palestinian, I saw Philippines, I saw many countries from different location in the world. Or the presentation was very complex that you don't really. But I tried to make it very complex that you know a lot of stuff happening in the world nowadays.
No more questions. Oh, any opinion? Does anyone want to answer Ahmed's question? No?
Have anybody heard about this initiative which I just mentioned? The 100-day mission, the Beret mission, the blueprint of the new prototype pathogen-based? No? I see one person raising his hand. Or? No? No? Anybody heard about Sustainable Development Goals? Okay. No one heard about this. Anybody heard about our suitcase lab? No. It was zero information before this presentation. Okay, that's also good. That means all this information which I just said, it's new for you. If this is true, please raise your hand if this is true. No reaction. Nobody raised their hand. If this is new, please raise your hand. Okay. Okay. Anyhow, I will share the presentation in the chat with all of you so we can have this presentation. You have my phone number if you would like to really react, or you would like to really contact with me or with Dr. Abdurrahman, also an expert. We are working together in many projects in UGM, and the suitcase is in his lab. So if you would like to have a look to the suitcase, you can visit his lab and see the suitcase in his lab. It's a very nice tool where you can do a lot of diagnostic directly in the field. So please feel free to use these tools. Feel free, whatever you are doing, please, this is my advice to you, please, whatever you are doing, link it to global initiative or local initiative. Don't just do like you spoke about the rabies problem before that. Before we start, please be sure if you would like to do that, take the advantage of the local initiative and see which local initiative fit my work, and I need to overlap my work with the local initiative. Thank you very much.
Okay, thank you once again. Give applause to Ahmed. Big appreciations to him and for his participation on these sessions. May you have a very good, still even it's in the morning in Germany, right?
It's still morning.
It's still morning. Yeah. Okay. Have a nice day for you, Ahmed. And see you in Indonesia next month.
Inshallah.
Inshallah, yeah. Okay, thank you very much, everybody. We now come to the end of our sessions. On behalf of myself, I would like to thank you to the committee and also to all of you to be patient to listen to us, and also to the presenters with a very insightful talks. And yeah, it must be very yeah, at least it can give you some a lot of new things, new information, especially for the last topics. Once again, thank you very much. If I make some mistakes by guiding these sessions, I giving back this to the Master of Ceremony. Assalamualaikum warahmatullahi wabarakatuh. Have a nice day.
Wow. Thank you, Dr. Abdul Rahman, for guiding us through this afternoon session. I see a lot of tired face today, or maybe that's because the session with Dr. Ahmed and no question, because maybe a lot of you are already tired, right? But I hope it doesn't make you down. But now we have reached the end of day one, and I personally happy to see your enthusiasm during our Q&A section from this morning until this evening. And thank you all for the participant, and thank you for moderators, and thank you for the organizing committee. So before we close this, we end this today, we would like Dr. Alvin, as the representative of organizing committee, to give the appreciation code to Dr. Abdul Rahman. Okay, everyone. Tomorrow, day 2, we will shift our focus to animal, livestock surveillance, and wildlife interfaces. So please be here by 8 a.m. And I hope to see you in a more energetic phase tomorrow. Okay, see you tomorrow, everyone. Thank you for your active engagement, and have a restful evening. Have a safe trip on your way back. Everyone, I want to say that
Recording stopped.